Good morning, everyone, and welcome to the 23rd public meeting of the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria. My name is Jemana Musmar, and I'm the designated federal officer for this advisory council. And I'd like to thank all of our presenters, attendees, and stakeholders for joining us today, including those who provided public comment. All public comment submitted to the PACCARB at HHS.gov mailbox has been provided to our council. So a little bit about the council. The advisory council was initially established via an executive order in 2014. And then in 2019, we were codified into legislation through the Pandemic and All Hazards Preparedness and Advancing Innovation Act, and thus formally reestablished under this statute as of September 2nd, 2020. The goal of this advisory council is to give the Secretary of Health and Human Services advice and recommendations to improve the programs and policies related to antibiotic resistance that would contribute to the overall health of our country. To accomplish that mission, the advisory council strives to address the issues related to antibiotic resistance through a One Health approach, which is evident in all of our proceedings and products. I'd also like to welcome our new 16 members of the council, 9 of which were in the voting member category, including the chair and vice chair positions, while the remaining 7 were in the non-voting liaison member categories. Newly appointed voting members were selected to serve 4-year terms, and non-voting liaison members were appointed to serve for 2-year terms. But before we start, let's do a few rules of engagement regarding this meeting and about PACCA. This meeting is being recorded and will be available on our website on HHS.gov/PACCARB. Second, the Advisory Council is governed by the Federal Advisory Committee Act, or FACA, where the majority of the work of this Advisory Council, including information gathering, drafting of reports, and the development of recommendations, is performed by designated working groups, who in turn report to the full Council for deliberation and final vote. Regarding the conflict of interest rules, all 15 voting members of the council are considered special government employees, or SGEs, and are subject to conflict of interest laws and regulations. The 12 regular government employee members, or RGEs, representing different agencies and departments on the council have also been vetted for any conflicts of interest. Lastly, I'd like to thank my amazing PACCARB team, Ms. Sarah McClellan, who is my alternate DFO, Ms. Haley Krem, Dr. Zaina Francis, Ms. Lauren Plain, and Ms. Jennifer Adana for their efforts to support the council and plan for this meeting. I will now go through a roll call for all of our council members, but please let us know if you're present by stating here. For our alternate representative members, please identify yourself and provide the name of the principal that you are representing today. So we'll go ahead and start with Dr. Stephanie Black. Are you with us?
Here.
Dr. Claire Burbick, good morning.
Here.
Dr. Virginia Fate.
Here.
Dr. Susan Wong.
Here.
Dr. Jenny Kwan.
Here.
Dr. Lubers.
Here.
Dr. Lynn Marks.
Here.
Mr. Armando Nahum.
Here.
Hi. Dr. Payal Patel.
Here.
Dr. Robin Patel.
Here.
Dr. Joni Sheftel.
Here.
Dr. Julie Simzak.
Here.
And Dr. Tom Whittam.
Yes, I'm here.
Excellent. Now moving on to our liaison members, Dr. Carla Hewson for the American Association of Extension Veterinarians.
Here.
Dr. Padmini Srikantia for the Bill and Melinda Gates Foundation.
Here.
Miss Emily Wheeler for the Biotechnology Innovation Organization.
Here.
Dr. Francisco Zagmut for EpiX Analytics.
Here.
Dr. James Adaskevich for the Minor Crop Farmer Alliance.
Here.
Dr. Lucas Pantaleon for the National Institute of Animal Agriculture. Dr. Elizabeth Dodds Ashley for the Society of Infectious Disease Pharmacists.
Here.
And Dr. Timothy Jenks for Wellcome Trust.
Here.
All right, fantastic. And I'd like to make sure that our chair, Dr. Paul Plumbers, is with us.
I am.
Excellent. Has Dr. Jason Newland been able to join us?
Oh, yeah, finally. Good morning, everybody. I
All
apologize
right.
for my chaos this morning, and I hope everyone's doing well. I am present finally.
It's a great start for every meeting. Now we can clear things out. Welcome to our chair and our vice chair. All right, now moving on to our regular government employees, please be sure to indicate your covering for the principal RGE that is here today. For USDA, Dr. Jeff Silverstein.
Here.
Excellent. Dr. Sarah Tomlinson.
Good morning, here.
Good morning. Dr. Kiss Robertson Hale.
Good morning. I'm Dr. Gamola Fort Mary, and I'm serving as Dr. Kiss's alternate.
Thank you so
Yes.
much for joining. For the Department of Defense, Dr. Paige Waterman. All right, moving on to HHS, representing ASPRO, the Office of the Assistant Secretary for Preparedness and Response, Dr. Chris Houchins.
Here.
All right, Agency for Research, Healthcare, and Quality, HRQ.
Here, Melissa.
Thank you, Dr. Melissa Miller. And for the CDC, Mr. Michael Craig.
Here.
For CMS, Dr. Sherry Ling.
Dr. Jasmine Dinsa as an alternate to Dr. Sherry.
Welcome, Jasmine. For NIH, Dr. Dennis Dixon.
Here.
Hello. For the Office of Global Affairs, Dr. Lynn Philpy.
Here.
All right. For US FDA, Dr. Bill Flynn.
Here.
Welcome, welcome. And lastly, for EPA, Office of Research and Development, Dr. Jay Garland.
Here.
Welcome, Jay. All right. Well, thank you all for attending this important meeting. Just a few more housekeeping items to remember. I ask that council members who wish to ask a question or have a comment to use the Zoom function to raise your hand by clicking on the reactions bottom at the bottom of your screen, box at the bottom of your screen. The moderator for each Q&A session will call on you. Once you've been called on, please remember to unmute yourselves by using the microphone button at the very bottom also of the screen, and then mute yourself afterwards, after your comment or question, to keep down any additional noise. So we're doing things a little backwards because in virtual land, everything can happen. And so with that said, I'm going to turn it over to Dr. Paul Plummer and our Vice Chair, Dr. Jason Newland, to open us up formally before we introduce our opening remarks.
Well, I appreciate that. Can you hear me, Jemana?
Yes, sir.
All right. I appreciate the opportunity to be here this morning and to kick off this December 2023 meeting of the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria. We all recognize that antimicrobial resistance does not respect geographic or political boundaries. And consequently, we need to leverage our US's unique resources and expertise to aid in addressing this global challenge. Today's meeting will review and highlight the federal activities of a number of our US government agencies related to their efforts, progress, and opportunities they see in the global response to antimicrobial resistance. This approach needs to have at its foundation a One Health perspective, recognizing that this issue impacts human, animal, plant, and environmental health. And I'm pleased to say that PACCARB reflects that expertise in our membership and discussions. On that note, as with Jemana, it's my honor to welcome a number of new voting members and liaisons to PACCARB. You bring new expertise and experiences from all One Health fields that will greatly benefit our work. Having been sworn in yesterday, we encourage you to fully engage with our efforts today and in the coming weeks on the working group we have developed to respond to the task letter from Secretary Becerra. We appreciate your willingness to offer your time and energy to our efforts. I'd also like to welcome back our returning members and would like to thank Dr. Jason Newland for his willingness to move into the vice chair role here on PACCARB after his transition from a liaison to a full voting member. Thank you, Dr. Newland, for being willing to partner with me and helping to chair this effort. And I'd like to turn the floor over now to you for comments.
Well, thank you, Dr. Plummer and Paul, and a big thanks to our staff, Dr. Musmar and team, and Haley and everyone, especially on a morning when things didn't go as planned for me. And you guys were wonderful. There's a lot of things that I have going through my mind with this incredible opportunity to serve and to be a part of such an important time. I'm so excited for this amazing group of people that have been assembled for this new council. We have some expertise that you all will provide that will help us as a country be leaders, not only domestically, but internationally, which is what this new task is called for us to do. As I sit here and think, and as I was thinking about my opening remarks, as a pediatrician and as a pediatric infectious diseases, children are my life, both my own children, but also my daily work. And if we think about globally, where you are might mean as a baby, think about a cooing baby, the most beautiful noise. Some have a mortality much greater. And one of the reasons it is because of antimicrobial resistance. If you look at a recent paper from Southeast Asia, our typical antibiotics for those with bad infection or neonatal sepsis, they won't cover the pathogens that are causing their neonatal sepsis. As a matter of fact, carbapenems, the most broadly coverage antibiotics, only cover 80%. Many of these countries might not even have the next line of antibiotics. So with that, our work is pressing for the most vulnerable. And I look forward to working with all of you and appreciate the public being a part of this so that we can drive the U.S. as leaders in the fight against antimicrobial resistance. Thank you, everybody. I look forward to a great day.
All right, I think we're going back to you, Jemana, for our introduction of the patient story.
Unfortunately, I think she's having some technical difficulties. Before our patient story, though, we're going to have some opening remarks from Lois Pace, who's the Assistant Secretary of Global Affairs at the Department of Health and Human Services.
Hi, I'm Lois Pace, Assistant Secretary for Global Affairs at the U.S. Department of Health and Human Services. I'd like to welcome everyone to the virtual public meeting of the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria. I would especially like to acknowledge and welcome the newest members of the Council who joined this fall. Your expertise and commitment to this Council are sincerely appreciated and highly valued. Each of you brings a unique perspective to the Council that will be invaluable in responding to the latest tasking from Secretary Becerra to explore and provide recommendations on how the U.S. government can lead global AMR efforts for sustained action domestically and internationally. The National Action Plan for Combating Antibiotic-Resistant Bacteria, or PACCARB, seeks to enhance international capacities to address the emergence, spread, and impact of antibiotic resistance in Goal 5. This is especially important in the context of supporting all partner nations, particularly low and middle-income countries. By executive order, my office, the Office of Global Affairs, is the HHS lead for PACCARB international efforts. As a diplomatic voice of HHS, our mission is to provide leadership and expertise in global health diplomacy and policy in service to the American people. It is our responsibility to ensure the U.S. priorities are included in international forums, negotiations, and deliverables. Today's meeting is an important opportunity to hear from federal departments and agencies actively involved in U.S. efforts to combat antimicrobial resistance, the WHO AMR Survivor Task Force, which provides a platform for those who have lived experiences dealing with complications from drug-resistant infections, and will discuss potential priorities for advancing U.S. AMR leadership internationally. As we move forward, we must continue to broaden the ways we address AMR. We all know that it is important to look at AMR from a human public health point of view, but we must also broaden the aperture to understand AMR through a global One Health and multi-sectoral lens. There are many challenges that must be addressed to minimize global AMR rates and associated impacts at the human, animal, and environmental interface. The United States leads by example by making evidence-based policy decisions on AMR, working closely with international partners, and assisting the efforts of the global community. There are several impactful U.S. government initiatives and projects focused on mitigating the effects of AMR that we are proud of and that make a difference globally. You will hear more today from my office on how OGA aims to protect the health and well-being of Americans through our work, supporting our experts and promoting our policies and actions to combat AMR on the international stage. While a pandemic might have slowed down our ability to respond to and reduce AMR, international attention on AMR priorities and policies is rising. The next year's UN high-level meeting is case in point. To build back better, we must reinvigorate political will and attention on AMR and continue to prioritize and elevate the importance of preventing and responding to AMR before, during, and after health emergencies. The 2016 political declaration of the UN high-level meeting on AMR was a milestone that brought about a paradigm shift in the global fight against AMR through galvanizing political leadership and recognizing the global threat facing us when we no longer have the antibiotics and antifungals that are a cornerstone of medicine. 2024 marks a critical moment in the global fight against AMR. The 2024 UN high-level meeting on AMR provides an opportunity to build on the success of the 2016 political declaration and take stock of our collective progress, as well as identify where major gaps remain in global AMR efforts. It provides a moment to do more by committing to clear targets and practical steps to address AMR. The 77th World Health Assembly will consider the adoption of a resolution on accelerating national and global responses to AMR, and the 4th Ministerial Conference for AMR will be hosted by the Kingdom of Saudi Arabia in the fall. There will be multiple opportunities leading up to the high-level meeting to not only prepare for September 2024 and demonstrate U.S. leadership, but also to ensure that our work will be grounded in equity, dignity, accountability, and results. These opportunities have already started, and we are taking full advantage of them. For example, I recently co-chaired the first in-person transatlantic task force on antimicrobial resistance, or TATFAR, meeting since before the COVID-19 pandemic, and heard firsthand the global interest in ensuring a successful and actionable high-level meeting on AMR in 2024. TATFAR leverages the knowledge and experience of some of the foremost AMR experts on both sides of the Atlantic and has proven to be an essential forum for international collaboration around key AMR areas, including domestic and global policy. Earlier this month, policymakers, the private sector, academia, and civil society recently met at Wilton Park in the UK to strategize how to reprioritize AMR on the political agenda, reflect on the current response to AMR, and identify what actions are needed from different sectors to drive meaningful change in years to come, including at the high-level meeting next year. And in February, an Evidence for Action dialogue on AMR will be hosted by Malta, a co-facilitator of the 2024 high-level meeting and vice chair of the Global Leaders Group on AMR. There will be focused on the most urgent research questions to mobilize political action to address the pipeline and access crisis of antibacterial products for human health. These opportunities and global discussions are all important milestones on the road to the UN high-level meeting on AMR and seek to complement and accelerate other ongoing coordinating global actions to address AMR through a One Health approach. As we seek harmonization across One Health sectors, much work remains to address gaps in financing, technical assistance, and capacity building. OGA is engaged in international dialogues to ensure that global partnership and collaboration on efforts to combat AMR recognize that mobilization of adequate, predictable, and sustainable sources of funding for implementation of national action plans and access to affordable antimicrobials continues to be a global challenge. The global ability to prevent and respond to serious AMR threats starts at the country level. But so many countries around the world continue to struggle in building their domestic capacities, mainly due to a lack of resources. While over 90% of countries have established AMR national action plans, less than a third of those countries have assessed the financial considerations for implementation or have developed a monitoring and evaluation framework. Of those countries with established national action plans for AMR, only 11% have made financial provisions to support AMR national action plans in their national budgets. Financing is key to sustainability, and sustainability is key to progress. It is critical that we consider this as we discuss actionable commitments on AMR and support countries' long-term capacity building. And we must also remember that new funding models are needed to support countries in delivering on their national plans. Beyond much-needed government interventions, civil society organizations, including academic institutions, have an important role to play in raising awareness about AMR as a serious public health threat and supporting the development of national action plans, the establishment of community-based interventions, providing hospital care, and promoting antibiotic stewardship. Civil society organizations can also aid the development of our research agendas by identifying gaps and contributing to global discussions, including bringing greater awareness about community struggles with AMR and also helping to ensure accountability from governments and the private sector. We feel strongly that all regions of the globe and all partners, especially on a local level, must be included moving forward to ensure health and health security for all. To deliver on our collective ambition of tackling AMR and maintaining steady progress, we need solutions at all levels that consider varying healthcare infrastructures, differences in regulatory frameworks, and differing economic capacities, as well as acknowledge the need for international cooperation to address this global health issue effectively. These solutions must be centered around the people directly affected by AMR and their communities, and must address their needs and the barriers to ensuring equitable access to antimicrobial products. Further, to develop effective solutions, we need good data collection and data sharing to monitor progress and identify where gaps exist. However, we still see challenges to strengthening surveillance and data collection with diverse systems and differences between how and what data countries or regions collect. Sustainable progress relies on data for clarity in decision-making, clear goal setting, ensuring accountability, and encouraging greater investment from governments and the private sector. While governments may lead on efforts to address complex challenges surrounding the AMR ecosystem, all sectors can also be taking a fundamental step toward combating AMR by preventing infections in the first place. With proper and sustained focus on addressing and improving human, animal, and environmental health systems, the need for using antimicrobials will be reduced. We need to continue to strengthen infection and prevention control in health facilities, improve sanitary practices in live animal settings, ensure access to clean water, sanitation, and hygiene, and enhance routine immunizations for vaccine-preventable diseases. Collectively, these efforts will lead to fewer infections, reducing the need for antimicrobials. With all sectors and all communities at the table, we can move forward together with science-based and outcome-oriented commitments that are actionable and attainable for all to ensure we build upon the progress made since 2016. In closing, I want to thank you again for your continued commitment to ensuring that the U.S. is a collaborative champion and global leader in addressing AMR through a One Health lens today, in 2024, and beyond. I look forward to the recommendations that will come out of this council in the coming months, which will be integral to shaping our policies and strategies for addressing this global health challenge, both domestically and abroad. With that, I will hand the floor over to Dr. Musmar.
We appreciate the Office of Global Affairs for facilitating the pre-recording for Ms. Lois Pace, and we appreciate her presence with us virtually through this pre-recording, and we look forward to further engagement. I now have the honor and true tradition for us to have our patient story from the WHO AMR Survivor Task Force, Dr. Noor Shemis from the Ministry of National Guard Health Affairs. Dr. Noor Shemis is an antimicrobial stewardship and infectious diseases clinical pharmacist with the Ministry of National Guard and Health Affairs. Dr. Shemis is a member of the World Health Organization AMR Survivors Task Force, and members of this task force aim to help shape the AMR narrative globally and influence policies that affect AMR. They also contribute to improvements in AMR messaging so that the human face of AMR is presented alongside messages that increase awareness of AMR. I now ask you to please turn out your attention to Dr. Shemis. Are you with us?
Yes, good morning and good afternoon from my end.
Good afternoon. Thanks for staying up for us.
No problem. Thank you so much for your kind introduction and for having me join you today. I'm really excited to share my perspective as both, as Dr. Musmar mentioned, an AMR survivor, caretaker, I'll elaborate on that, and also a healthcare professional. I deal with AMR on a daily basis at our healthcare facility. And also thank you for whoever is taking care of the slides. I'll just ask you kindly to next slide, please. Thank you. So I'm originally from Lebanon. I grew up 10 minutes away from the Pigeon Rocks, if you're familiar with that. I also grew up 10 minutes away from a Palestinian refugee camp where I was very early on exposed to inequities. I grew up in a very privileged background, basically. But part of my upbringing had me really encounter what inequities could look like and how infectious diseases could impact people really early in their lives. And that's one of the reasons I decided to study pharmacy and look at medication errors and infectious diseases. And as you mentioned, I now chair the Antimicrobial Stewardship Committee as a pharmacist, which is also not a really easy thing to do in general, in terms of finding ways to collaborate as a healthcare worker, as a pharmacist, alongside a big group of people. And what changed in 2018 was that I became a daughter of an AMR survivor. This is my lovely mother. Her name is Noha. Next slide, please. Thank you. So in 2018, I was at a conference in San Francisco, actually, attending an amazing lecture about how we can now combine ceftazine avibactam with aztreonam, because at my facility, we were struggling with a bit more resistant organisms at the time. And I took this photo because I was so excited about how we can start looking at new therapeutics to actually make a difference. We were seeing a lot of MDRs at the moment. And in the afternoon, I got a call from my mom in Beirut saying that she's going to have an emergency back surgery after exercising too much, basically, because she was trying to lose weight, because Beirut is a very big city and it was really difficult. So just understanding the different layers of how, people with comorbidities, what they have to face. And so she had to have this emergency back surgery, and we understand that there are many risks. She understood it. She's a relatively medically literate person. Unfortunately, and 2 months later, she started complaining. She didn't complain early enough, but because she thought she didn't want to be too, spoiled, basically. She didn't want to share that she was having any new issues. So she then started having I'm sorry, I don't know if my connection is bad. If you can't hear me, let me know. Good, okay. So she started developing pain basically on urination. So she had pyelonephritis, a bacteremia. She required infectious disease consultation, and I'll come back to why this is important. She required isolation, and any of us who have worked with the patients that require isolation know how isolating it is for the patient, and it's not just a risk for infection control. She required IV antibiotics, which I'll also go back to. And we're very privileged because we have a really good health insurance, and she had access to one of the best hospitals in Beirut. But then, even though we had really good healthcare, she then, after a couple of months, started having recurrent infections. And so she now self-manages. She knows what a UTI is, what pyelonephritis is, what bacteremia is. And this has been a big change for us. Next slide, please. And so what changed for me is from going from a healthcare practitioner that understands AMR from a very medical perspective. And although I'm generally very empathetic with my patients and I understand what they go through, but having specific questions from my mother really changed my perspective on AMR. So for example, my mother knew to ask people to conduct hand hygiene and show her that they've done that before touching her. My mom understood AMR. She knew what the acronym means in English, and she understood it, how to explain it in Arabic. She advocated for not taking antibiotics for viral illnesses. But then when she developed the UTI, she asked me, why me? What did I do wrong? Why do I have to take an IV antibiotic? And why can't I get rid of it? So that specific question really hit me really hard, because how do you explain hospital-acquired infections to someone? And how do you share that, and also given that this is a urinary tract infection, this is not an STD, how do you explain that to someone who really, this is a genitourinary tract? How do you, really explain it to someone? And so also thinking about the fact that I can't really tell her that this is catheter associated. So I can't really blame the catheter because it doesn't fit the typical, let's say, insurance-based definition of catheter associated urinary tract infection. She also actually refused to have ID consultant come and see her because she was worried that that's going to create future stigma on her patient file, because, you know, why does she have ID visiting her? What is wrong with her? Also, she asked me a very interesting question, and that was, why is it that women, because I was telling her that women tend to have recurrent UTIs, trying to make her feel that this wasn't just her. And she asked me a question, why don't we have good antibiotics for women so they don't have recurrent UTIs? And I didn't have a good answer to that. And that's when I started looking and reading up on the discrepancies between women and men and recurrent UTIs. And why do we just accept recurrent UTIs as just another infection? We just accept it. So this really changed my perspective on AMR as a disease and the social impact. Next slide, please. So in addition to the isolation and the anger, and there's a lot of shame, and I don't know how to describe to someone that an ESBL E. coli infection is not a big deal, because I see pan-resistant Acinetobacter every day. But to her, that was a very big deal, and having a recurrent UTI, having to have IV therapy, home IV therapy, which we could afford, but most people couldn't. And I'll just, maybe for those of you who aren't aware, Lebanon is going through a very, very bad economic crisis, meaning medications aren't available. So I had to smuggle in antibiotics with a prescription, of course, from where I work, because my mom had visited and she has a good connection with her physician here. But there were medications that we can't access, like fosfomycin, like ertapenem. So the simple medications that we are now thinking about, and the concept of access, and Ms. Pace mentioned earlier about how the importance of access, especially in low to middle income countries, and that's something we really face every day. Next slide, please. So throughout my journey, I went from being a clinical pharmacist, because I'm really interested in fixing things, to understanding that it goes beyond having to fix the same problem every day, having the same type of patient come in with an ESBL E. coli or a pan-resistant Acinetobacter. So thinking about project management and antimicrobial stewardship in general, and then that's what took me to studying global health policy, and then also looking at how do we incorporate the patient perspective, how do we explain, how do we preempt hospitalization related adverse outcomes by explaining to them things that they could face in the future, and do we scare them, you know, just understanding the anthropological perspective of in AMR. Next slide, please. So this is, as mentioned earlier, this is a WHO AMR task force. I'm not the only one to have faced this. This is a very small group, and we're not in any way representative of the AMR patient, basically load, but we do have a very diverse backgrounds, talking about patients with a background of bacterial infections, gram-positive, gram-negative, HIV, tuberculosis, fungal infections. So really, it's not just about bacterial resistance, it's about antimicrobial, microbial resistance in general. And people with really different problems. You can see, next slide, please. On our website, you can see different stories of different patients, and I really encourage all of you to read all of the stories so you can get a different idea of what each and every person has gone through. Some of us have faced perfect, ideal situations and still had bad outcomes. Some of us had issues with not even having access to a urinary culture, or no one thought about taking the right diagnostic at a time, or giving a patient an antibiotic because the clindamycin instead of a beta-lactam, because they thought that maybe the patient might be allergic, and that person had to have, I think, 15 surgeries after that time. So next slide, please. So the AMR task force is really, I think, really innovative, and I really hope that you can invite many of our members, and also members in your community if you don't have access to us, and I'm sure you will, but invite all of us to join you in different presentations. Next slide, please. And this is a webinar that's also available online on the WHO task force. And I think Dr. Mismar mentioned already a bit of the terms of reference, but basically we aim to bring our stories to policymakers, to also the public, just so that we can have a different way of talking about AMR. AMR is an acronym that in Arabic, just as an example, we would need 5 words to describe AMR in Arabic, rather than using a 3-letter acronym. of AMR is a really big issue. Next slide, please. Thank you. So then the next point here is just looking at the people-centered approach and addressing antimicrobial resistance in human health. And you see that the major foundation is having AMR advocacy. And this is part of it is having AMR survivors as part of the task force. And we're not talking just about people who come to conferences and, you know, have the opening remarks, although this is really amazing, but having us as part of your committees, collaborating with us in research and understanding, you know, what our priorities are, so that things can really change from the perspective of patients, because at the end of the day, we're all doing this for patients. So we might as well have them have a voice with us. Next slide, please. Thank you. So these are just some of my take-home points from my experience, and I hope to share it with you. So AMR can really happen to everyone. And we're, again, just highlighting that people suffer from bacterial, viral, fungal, parasitic infections, and all can be resistant and all can have access issues. And there's a lot more work that is needed to define and describe the problem, with considering that language is a barrier. So do we talk about inflammation? Do we talk about infection? Do we use the acronym AMR? Should we keep it as antimicrobial resistance? All of these questions that are, you know, debatable. Having patient advocate representation, either permanent or ad hoc, as I suggested earlier, and having, you know, the real perception that AMR is a side effect of basically unhealthy healthcare systems. And I think, you know, many of us know this, thinking about One Health and thinking about how political and economic strife can really worsen AMR. In Lebanon last year, we had episodes of cholera, which we had never had, which we haven't had in a very long time. This is a spillover from the Syrian war. Now with the current events, I'm sure things are going to be also really tough. Next slide, please. Of course, research on new drugs is really important, but access is really the biggest issue at this point, and the biggest part of the low middle income country communities. But you'll see that in the patient stories, even in the United States, there are questions from the patient survivors about, you know, why didn't anybody test me early for this skin and soft tissue infection? Just general awareness at the bedside. And so really multidisciplinary action is the way to go. And we're not talking just about pharmacists and physicians, but also nurses, infection control practitioners. At my facility, we now have an AMR, an antimicrobial stewardship nurse who is helping me co-lead our stewardship efforts, there's a real liaison with nurses, because nurses are the biggest healthcare professional task force. Health systems, like I mentioned, and the last thing is to really think outside typical health systems. You know, so it's not just about One Health, it's also looking at housing, looking at maternity leave, thinking about, you know, equity in research. You know, how many women are really part of high-level advisory boards, early education. So, you know, I grew up understanding pollution, understanding that we really need to be symbiotic with our environment rather than just being a parasite and just, you know, taking everything from our surrounding. And of course, thinking about AMR from a national and international security perspective. So next slide, please. Thank you very much. I really hope that I was able to bring across my perspective, and I look forward to your questions if there is time. And this is my contact information if you have any questions in the future.
Thank you so much, Dr. Shamaz. I think we have a couple minutes for Q&A. If any of our council members have any questions, please go ahead and raise your hand. I can go ahead and call on you. Oh, Dr. Newland?
Noor, thanks so much. Thanks for taking the time, spending a part of your day with us to share that incredible story. And I'd say that all of us have probably a loved one or somebody that we could probably think of that maybe is being contacted by a pathogen. And I love how you mentioned AMR is more than bacteria, and I think that's super important. I guess my question to you is, as you look at this from Lebanon, a place that is around a lot of inequities, as you mentioned, and political strife. And I'd say war is bad for everything and everybody, and AMR. What is our biggest challenge globally? Is it access? Is it really just the infrastructure of a world that's torn? What do you see as a patient, healthcare provider, and a caregiver?
Yeah, I keep thinking of that, and that's the reason I studied, did a master's in global health policy to try and understand how do I change my approach to the solution? And I think the biggest thing is education first. So again, it's just about, just generally understanding our resources, and are these your resources? Is this the global goods? Can you monopolize something? How do you change people's perspective early on so that you have stewards in growing up early on? Water, oil. I grew up being from my mother telling me, don't use too much water, because people in Saudi Arabia don't have a lot of water. And here I am working and living in Saudi Arabia, where water access is really, easy, whereas in Lebanon now, which, it's not. So I think that is the biggest problem. Now, that's not a very easy problem to fix. And so maybe the first thing that's maybe easier to fix, although it is, if you do change educational systems, I think that it needs to start now. So you can have in 15-year-olds who understand stewardship. But the other thing is access. So making sure that people have access to amoxicillin is basic, ceftriaxone. If you look at the literature that's published in high-income countries, we talk about carbapenem resistance, and whereas in other places, of course, carbapenem resistance exists, but people don't have carbapenems. People don't have ceftriaxone. So if you look at medication use trends, you might not have the same trends, not because of people don't use it, but because they don't exist. They're not accessible. So I think access and education are the two number one things.
Thank you so much. Any other questions for Dr. Chamath? Hearing none, I want to thank you so much for joining us, Dr. Chamath, and sharing your story. Really, really important and powerful messages. And I will turn it over to Drs. Newland and Plummer. Thank you.
Wonderful. Thank you. And I too want to echo my appreciation, Dr. Chamath, for a presentation that was personal and meaningful, and for your time to visit with us today. Transitioning now to starting our component of hearing from the government agencies, a little bit of background from Jason and I, just to transition to this process. So in the fall of this year, the PACCARB was provided a new task by the Secretary of HHS. The Council was directed to provide recommendations on how U.S. government agencies can lead global AMR efforts. The PACCARB will evaluate global AMR from a One Health perspective to provide recommendations for sustained action on combating AMR. You can transition to the next slide. This task is particularly timely given the focus of the UN General Assembly in 2024 being on antimicrobial resistance. And then the next slide. So this is the task letter provided by the Secretary, and that is available on the PACCARB website for folks that would like to review that. In the next slide. So our working group was established in December of 2023 in response to that task letter. The working group will be meeting regularly to collect information, discuss approaches, and ultimately synthesize a draft report to be brought back to the full PACCARB for vote. In addition to working group administrative meetings, we will have one additional public meeting held in late February to hear from experts on several topics for which the working group is seeking additional feedback. In May, the working group will present the draft recommendations back to the full PACCARB for vote. With that background, I'm going to transition to Dr. Newland for an overview of our goals today and some additional guides.
Yeah, so our big goals for today and the objectives of today are to understand the landscape of our U.S. federal government's antimicrobial resistant or AMR activities. Additionally, we'll highlight some successes, achievements over the past 10 years since the, I'd say, landmark National Action Plan in 2015, and then identify gaps and areas for renewed focus. Again, the task really is to look at our global AMR and how we, as a country, as a major leader in the world, can help and do more with our with the global AMR. And as Dr. Plummer or Paul mentioned, is that we have UN General Assembly here coming up in the fall of 24. So now I'd like to introduce our first module, and our first module today is focused on the Office of Global Affairs, which is the health diplomacy arm of the U.S. Department of Health and Human Services. Office of Global Affairs will say it referred to as OGA. You will learn those new council members. There's a lot of acronyms, and I'll try to go back and forth. I'm also trying to keep up. I'd like to thank each and all of you who have joined us today to present. We really appreciate all your efforts as we work on AMR. So our council representatives to the OGA, Lynn Philpy, will provide a brief introduction, and then that will be followed. We'll hear from Ms. Gabrielle Lamarelle, Mr. Peter Schmeisner, and Dr. Miranda Smith about how OGA addresses antimicrobial resistance. We're super excited to hear from you. We'll have some discussions and questions after each of these individuals present. And so I will now turn it over to Lynn. Lynn, please go ahead.
Thank you very much, Dr. Newland, Dr. Plummer. We really appreciate the council inviting OGA to speak today. And I also want to add my thanks to Dr. Shamaz. That was an excellent presentation and really appreciate your unique perspective. Also, I'm just really pleased to hear that there is a patient-focused advocacy group now for us to work with. I think that's been a missing piece of our global response for quite some time. So really excellent presentation. The Office of Global Affairs, as you've heard, is the diplomatic voice of the U.S. Department of Health and Human Services and supports Secretary Becerra as his global health advisors. We coordinate international engagement across HHS and the U.S. government on human health issues, but we do this with a One Health approach. We provide leadership and expertise in global health diplomacy and policy to contribute to a safer, healthier world. OGA takes the lead on engagement with the World Health Organization, WHO, and the Pan American Health Organization, PAHO. But we also lead on health tracks in various foreign initiatives such as the UN, G7, G20, and others. You'll hear from my colleagues on these efforts in more detail in a moment. Global health diplomacy is the intersection of global health and foreign policy, and it's the core of OGA's work. OGA does this by building relationships with multilateral organizations, foreign governments, ministries of health, civil society groups, and the private sector. And OGA creates and maintains the pathways for HHS to apply its expertise globally, learn from our overseas counterparts, and advance policies that protect and promote health at home and worldwide. In addition to our regional teams in our office, OGA has dedicated policy teams that are dedicated to health and trade, PEPFAR, and pandemic and emerging threats where AMR sits. We also have overseas staff embedded in embassies. Currently, there are health attachés in Brazil, China, India, Mexico, Kenya, South Africa, and Geneva, Switzerland. Next slide, please. So this first slide is from the Graham Report, which I hope you're all familiar with. The researchers used data from 204 countries and 23 bacterial pathogens and 88 drug pathogen combinations to estimate that 1.27 million deaths in 2019 were directly attributed to drug-resistant infections. They also determined that 4.95 million deaths globally were associated with AMR. Globally, misuse and domestically, misuse and overuse of antimicrobials are the main drivers in the development of drug-resistant pathogens, but also lack of clean water, sanitation, and inadequate infection prevention and control promotes the spread of microbes, some of which are resistant to antimicrobial resistance, which this council knows well. The cost of AMR to the economy is significant. In addition to death and disability, prolonged illness results in longer hospital stays, the need for more expensive medicine, and financial challenges for those impacted. Added on to the cost of directly attributable infections, if unaddressed, we will lack effective tools to treat secondary infections and will no longer be able to perform routine life-saving procedures such as C-sections and organ transplants. Importantly, efforts on cancer and pandemic response will fail as mortality due to secondary bacterial infections will increase in those patient populations. Next slide, please. The next slide is a timeline of our efforts on AMR. The top is domestic efforts and the bottom is international. WHO has declared antimicrobial resistance to be one of the top global health threats. In 2015, member states endorsed the WHO Global Action Plan for Antimicrobial Resistance, or GAP, to provide guidance to countries on building their own national action plans, or NAPs. I'll note that while 90% of the countries have developed an AMR action plan, only 20% have identified funding for implementing and monitoring these plans. Again, the top part is focused on domestic efforts, and I'd like to call your attention to the left side. To strengthen domestic and global capabilities for combating antimicrobial resistance, the Obama administration took executive action in 2014, which Jomana mentioned earlier. It's what established this PACCARB. But in addition, it established an international working group. This was tasked to the secretaries of HHS, State Department, and USDA, and we were directed to take a One Health approach. This working group determines and advances USG policy on AMR globally. HHS, the secretary at the time, directed OGA to lead, and we have been the de facto organizers of this effort since. Currently, we are using this group to discuss the upcoming UNGA high-level meeting and the various policy options the US should consider. Next slide, please. So you've heard a bit about the strategy, and I'm not going to read through this completely, but this was the original strategy that was put forth in 2014, 2015. And the CARB Task Force used this strategy to build the initial NAP and also to build our second and current NAP. In shorthand, we break it down into prevention and stewardship, surveillance, R&D, not only for new therapeutics, but also for vaccines, diagnostics, non-traditional therapeutics, decolonizing agents, etc. And the fifth goal is global. Next slide, please. So our goal 5 has an overarching target of improving international collaborations and capacities for antibiotic resistant prevention, surveillance, control, and antibiotic research and prevention. So in order to do this, we have 4 umbrella goals. We enhance US leadership, we promote increased awareness and capacity, we generate data through better surveillance, and we increase international collaborations. Last slide, please. I just want to quickly outline for you a few of the things that Assistant Secretary Pace mentioned in her opening statement. There's quite a bit going on this year leading up to the high-level meeting. We are currently negotiating a WHO resolution for the Executive Board in this year's World Health Assembly. We are, as I mentioned, developing US policy for the UNGA high-level meeting and looking forward to that high-level meeting in September of this year. Italy and Brazil are leading the G7 and G20 respectively, and we are working with them to advance AMR efforts there. And then the Kingdom of Saudi Arabia will be hosting the 4th ministerial in November, and we're happy to work with Saudi Arabia on that issue as well. But I also want to highlight for you that while these are some of the large meetings that are going on this year, there's a lot of additional work that goes on every year, whether there's a high-level meeting or not. And so I hope as this council deliberates, we don't forget all the other foreign initiatives where we do work and where there are opportunities for increased attention. These include the Transatlantic Task Force for Antimicrobial Resistance, the Global Health Security Agenda AMR Action Package, and the Global AMR Research and Development Hub. Next slide, please. And with that, I will turn it over to my colleague, Gabrielle.
Thank you, Lynn. The Office of Global Affairs leads for HHS on preparations for the UN General Assembly. working closely with the Department of State, and I'll talk a little bit more about what that means. So these preparations include supporting the Secretary of HHS and working with our colleagues within HHS and other departments and agencies to prepare for UNGA and its related events. Next slide, please. The UN General Assembly cycle begins each September with meetings and committee work that continues throughout the year. So during this high-level week, heads of government meet to discuss critical issues in international cooperation, economics, diplomacy, development, and increasingly in health. At UNGA, a high-level meeting, or HLM, is an event or a specific issue or on a topic mandated by the General Assembly resolution or decision. It includes participation of heads of state, heads of government, and government ministers. The president of the General Assembly chairs a high-level meeting, and 2 co-facilitating delegations, usually from the Global South and the Global North, lead its preparations. So since 2011, we've seen an increasing occurrence of high-level meetings that are focused on health, as you see in this slide here. And unusually, last year, there were 3 high-level meetings on health. It was quite intensive. These were on universal health coverage, tuberculosis, and on pandemic prevention, preparedness, and response. And each of those meetings adopted an outcome document or a political declaration that included mentions of AMR. This slide also shows some of the upcoming high-level meetings indicated with crosshatching there based on adopted resolutions, including next year's meeting on antimicrobial resistance. Next slide, please. So the high-level meeting itself is a formal event and it includes an opening session. It may include adoption of a negotiated outcome document, a plenary statement plenary statements that are delivered by the almost 200 members of the General Assembly, concurrent panels that engage a range of stakeholders, and a closing segment. But as many of you know, much of the activity around a high-level meeting actually takes place outside of that formal event. So this includes informal side events, meetings, and conferences that are timed to take advantage of the major influx of officials and stakeholders to New York. Bilateral and multilateral meetings also take place, and these engage counterparts, exchange ideas, sign agreements, and more. In terms of outcomes, member states often negotiate an outcome document. Most recently, this has usually been a political declaration. And these set out the collective ambitions of the General Assembly. They may commit to take certain actions, assign tasks to UN agencies, such as the World Health Organization, the UN Environment Program, or the Food and Agriculture Organization, or other UN agencies, and call on stakeholders to take certain actions. So UN declarations are generally not legally binding. However, they represent the commitment of member states to move in certain directions and follow certain principles. And since these are negotiations among governments, they can invite or urge other stakeholders to take certain actions, but they cannot specifically direct those actions. Next slide, please. In 2016, the high-level meeting on AMR adopted a political declaration that included 8 commitment areas, and you see these here on the slide before you. This slide shows the quadripartite's view of progress on those 8 commitment areas and views that many share. So these include, this really highlights that commitments with both specific actionable language and a primary stakeholder for action show greater levels of implementation. So you see that with the green mark against countries developing national action plans and on establishing the interagency coordination group. Other areas that lack the specificity are both more challenging to track their progress and maybe challenged in their implementation. So you see some mixed progress or very little progress on the other areas of commitments in the declaration from 2016 around supporting implementation and further development of NAPs, around funding issues, around surveillance, monitoring, and regulatory frameworks, awareness and behavior change, and a multi-sectoral One Health approach, as well as around the global development stewardship framework. It's important to note that declarations are political documents. That's why they're called political declarations. So while their contents really should be grounded in evidence, they also need to speak to leaders, to policymakers, to decision makers, and other stakeholders. Next slide, please. Discussions within and across the human health, animal health, and environment sectors will inform the outcomes for this high-level meeting. The negotiations themselves will take place in New York among governments, with negotiations on its format taking place likely in early this coming year in January or February, and negotiations on the expected outcome document will likely officially start in the spring. But ahead of this, we can expect discussions organized by the co-facilitators of the process, Malta and Barbados, by the group of Friends on Tackling AMR and others. Engaged counterparts and stakeholders are also starting now across forums, conferences, and other settings to surface and exchange ideas on the key content for a political declaration. These efforts from governments, researchers, civil society, and the private sector can help crystallize key issues and inform those New York-based discussions. But really importantly, they also foster and sustain the connections that we'll all need to take the actions forward beyond September. Political declarations are important, but what's even more important is what comes after in order to see their implementation through. And as Dr. Philippi noted, this coming January, the WHO Executive Board will discuss AMR as an agenda item and consider a draft resolution that's being negotiated. It'll then be discussed by the full WHO membership during the World Health Assembly in May 2024. And the United States is represented on the WHO EB, currently by Assistant Secretary Pace, who you heard remarks from this morning, as our alternate U.S. board member. And these settings are really important opportunities to discuss and to find consensus on critical actions on AMR. Next slide, please. So UNGA is an important space to elevate and bridge discussions across sectors, not only the animal, human, and environment, but also to bring in a whole of government and a whole of society perspective. Delegations are often led by heads of government, by ministries of foreign affairs, and include not only health ministries, but may include treasury, environment, and others. This slide shows you some of the key issues that are being discussed around UNGA in terms of what may be productively carried forward in a declaration, as well as actions beyond the high-level meeting to successfully address AMR across prevention, diagnosis, and treatment. So these areas include targets, how to set measurable, meaningful, effective targets that are likely to be taken on board by partners, monitoring and governance for action on these commitments, funding to catalyze and sustain progress that's needed, equitable access to tools across prevention, diagnosis, and treatment, environment and incentivizing the application of best practices, R&D across the One Health sectors, surveillance within and across these areas to make the best use of available data and increase the utility of the data that's being collected, education at multiple levels and building public trust, and then the intersections with other priorities and broader discussions on international cooperation. For example, the UN Secretary General during the same high-level week will convene a summit of the future that looks at how to accelerate progress around the Sustainable Development Goals. And as we know, AMR is a multi-sectoral issue with many implications for countries and communities. Geopolitical concerns that are beyond the specific health matter of focus also provide a backdrop around UNGA negotiations in a high-level week. So the co-facilitators will aim to reach consensus on a declaration, and that means that it needs to bring together priorities and perspectives across resource settings, capacities, and political views. So that's a brief overview of UNGA and our involvement there, and we look forward to hearing your views on accelerating action. And I'll now hand over to my colleague, Peter Schmeisser.
Thanks, Gabrielle. Next slide. Okay, yeah, I'm Peter Schmeisser. I'm in the Office of Global Affairs, and I'm Director of Europe and Eurasia, but because Europe and Eurasia and countries are very prominent in the G7, G20, I also cover G7 and G20. And just to say that HHS leads on the health tracks of the G7, G20, but there are many other sectoral tracks that other departments lead on. And so we have the interagency processes to make sure we're connected across the different tracks, whether that's agriculture, environment, trade, finance, or other things. Next slide, please. Okay, so I'm going to go over a little bit about the structure and processes within the G7 and the G20. I think it's important to understand these before I get into the topics of AMR. But in many ways, what I'm going to say echoes what Gabrielle described about the UN high-level political declarations. So the G7, we'll start with the G7. It's the older group. It's comprised of Canada, France, Germany, Italy, Japan, UK, United States, and then the eighth member of the G7 is the European Union, represented by the European Commission. As you'll see, these countries represented in the G7 are leaders in many ways on research, but also leaders on policies, especially policies related to AMR globally. So there has been a long-standing interest on AMR in the G7. The G7 is not an organization, it's a forum, so there is no secretariat associated with it. It has no offices. It's basically up to each year's presidency to determine how it's going to be run. And each year's presidency then provides the staffing and the resources needed to carry out the meetings of the G7. But it is not a standing organization, and so that makes it very dependent on each year's presidency. The presidency rotates each calendar year and determines the topics that it wants to cover. Intergovernmental organizations in other countries can be invited to participate. That can be at the leaders level, but also it's really up to the ministerial tracks to determine who they want to invite. So of course, the health track usually always invites WHO, World Bank, and OECD and others, but also the invited guest countries is really up to the presidency country's ministry to determine. There's basically the G7 really exists at the leaders level, the head of state level, but underneath that, depending on the topics that the head of state level wants to cover, there are many different ministerial tracks represented by and driven by the ministries of those countries. The summit, the Leaders Summit, is the high point of the G7 year. And usually most of the ministerial meetings happen before the summit to be able to feed their information into the summit. But sometimes they can occur after the summit and basically react to callings from the summit at the leaders level. But really the height of the energy is around the head of state meeting. Outcome documents are produced, but like Gabrielle described, these are not binding agreements. They're simply statements of political will and ambition. And it's important to note that at the leaders level, if you get a topic into the leaders declaration, there's an accountability working group that tracks progress on those commitments. That does not exist at the ministerial level. Next slide, please. Okay, so the G20 is a newer group. It formed in the early 2000s, and it really formed out from the basis of a meeting of finance ministers. So it's very much strongly grounded in finance and economic issues. The G20 includes the G7 countries plus the countries listed here, which do not necessarily represent the highest 20 economies, but are representative also of rapidly developing economies and others. The G20, importantly, the G20 since last year now also includes the African Union in addition to the 20 members. And in this case, the European Union is one of the 20 rather than the extra one like it is in the G7. The G20 members account for a significant portion of the world's GDP, trade, and population. Again, it's not an organization, but it's a forum. So just like the G7, it's dependent really year to year on what the presidency wants to do. In the G20, there's much greater connection, I think, to stakeholder groups. They have many different groups like the B20, the Business 20, the C20, Civil Society 20, the S20, Science, and others that basically help to organize stakeholders around the G20 and connect to the G20, which is governments. Also important to note that there are a few countries like Spain and others that basically are not true members, but they are always present as an invited guest. And again, the highlight of the year is the summit at the head of state level. Next slide, please. Okay, so it's important to know the processes by which the political outcome documents are developed and also other initiatives. So basically, as I mentioned, the presidency decides what themes it wants to cover, and it may also already at the beginning of its year already propose possible initiatives. Then there are a series of meetings held through the working group. So health is represented by a health working group, but there's also an agriculture working group. There's an environment working group. There's a development working group. And these meetings allow members then to really discuss the topics that the presidency has proposed. And sometimes member states will add other topics to the mix as long as they fit into the general themes. And member states also can propose new initiatives, but ultimately it has to have the backing of the presidency country. And ultimately there needs to be consensus across all G20 countries. Not only what's stated in the declaration, but also if there are any initiatives coming out of the G20. So basically, after a series of working group meetings, when you get closer to the ministerial meeting, that's when you're working on the outcome declaration. And that usually requires several rounds of review to come to consensus on the actual political text of the outcome declaration. Later in the process, as the process moves forward, it's harder and harder to introduce new things, but then you're really kind of refining and defining what is going to be the public outcome of the G20. Next slide, please. Okay, so in addition to the outcome documents, there are ways that the G20 can accomplish things. So I've listed a few here. One is that basically G20 and G7 statements of political will, once something is stated in the outcome document, it serves as kind of a driver to pursue things at the national level. It is important to note that, you know, G7 and G20 countries can only agree on things that they can do. They can't be tasking other countries. You know, that gets into the realm of the World Health Organization with all of its many member states. But frequently, and I would say mostly, most of what the G7 and G20 do are not just internal to those countries. They are outward looking and they are global. So it's basically, how can the G7 and G20 countries help the world achieve progress on the issues of importance? Okay, and the next point is that basically these G7 and G20 countries, they're also fairly influential in the broader discussions, such as at WHO. Again, because they have fairly deep in resources and expertise, they basically often help guide the discussions in the broader multilateral fora. Okay, the G7 and the G20, they can stand up initiatives, but it's very important to note that these initiatives, once they're stood up, they either have to spin off and be freestanding and not connected to the G7, G20, or if they're going to stay something that's G7 and G20, they need to get the agreement of the next year's presidency. So it's a little bit more difficult to stand up something that's going to be a G7, G20 thing over many years, because most presidencies don't want to be burdened with something from the previous years. They want to have their own signature projects, and so they don't want there. Otherwise, there would be a piling up of G7 and G20 work that would be unmanageable. So really, mostly whenever something is initiated and it's meant to exist over multiple years, it really has to spin off and become its own entity. And then during the presidency year, of course, there can be projects undertaken that are completed within that year. Usually these are things like collecting information and writing reports that can easily be finished within the presidency year. But there are sometimes working groups and task force set up that are meant to go from year to year. Okay, thanks. Next slide, please. Okay, so AMR, I'll just give a little bit about AMR in the G7, G20 over the years. So the G7 since 2015 has really had a standing health working group. Before then, it was hit or miss. Maybe some years would have a focus on health topics, other years wouldn't. But since 2015, really since the Ebola outbreak in West Africa, there's been kind of a standing focus on health. And already in 2015, there was quite a lot on AMR put in the outcome document. Generally, all of the different elements of AMR are noted in the outcome documents, whether it relates to stewardship, whether it relates to surveillance, or whether it relates to R&D for new antibiotics. So if you look at the 2015 G7 Health Ministers Declaration, you'll already see a lot on AMR in there. The topic of AMR then usually has been repeated and carried through from year to year, and just some high points. So in 2015, the G7 compiled a brochure of best practices and called for the 2016 high-level UN meeting. In 2016, they discussed the international review on AMR. In 2017, there was a focus by chief veterinarians and others to develop definitions from a One Health perspective of AMR. And then in 2021, there was a focus on the financing, also starting to get into pull incentives and not just push incentives. And in 2023, we're really coming out of COVID and calling for a refocusing on AMR. The G20 health track started a little bit later. It really took off in 2017, I would say. And actually in 2017, from the German Chancellor's office, not from the health ministry, they actually developed the Global Collaboration Hub on AMR R&D, which was meant to basically landscape, be a dashboard and a platform to track research and development on new antibiotics and also opportunities for influencing that governments could tap into. 2018, there was a tabletop exercise held among G20 health ministers. 2019, they welcomed the IACG report. 2020, there was a side working group, a side session on financial incentivizing R&D for new antibiotics. And 2021, there was a welcoming of the Global Leaders Group and the Independent Panel on Evidence for Action Against AMR. I think that's maybe it for that slide. Okay, well, anyway, I will wrap up, but basically AMR has been consistently covered in the G7, G20. It has evolved, discussion of it, I think, has evolved as there have been developments in the AMR world. So in the beginning, it was really just noting the problems and the issues. And because both of these fora are grounded in basically economics and security issues, you know, it was fairly straightforward and easy to pitch AMR as an important topic because it has such dramatic economic and security impacts. And then over the years, again, there have been, sometimes it's been more closely covered, sometimes less closely covered. But now I think it's really evolved into, you know, there's been a lot said already, for example, on the financing of antibiotics. Now it's really up to countries to come up with their initiatives on how they're going to drive antibiotic development and showcase those at the G7, G20. On surveillance, there has been a greater recognition of, you know, connecting across the One Health sectors in terms of surveillance. In stewardship now, there's really infection prevention and control has always been a topic, but now it's really gotten to, at the global level, a focus on not only stewardship, but also access to antibiotics and how do you balance between the two. So I would say that AMR is a work in progress in the G7, G20, but there's still a lot of opportunity to get the G20 and the G7 to focus on them. They're very receptive to AMR as a topic. And again, they can be influential if they put their mind to it. There have been initiatives that have come out of the G7, G20, such as the Global Fund, such as the Pandemic Fund recently. So at times, you know, big initiatives can arise from the political will from the G7, G20. That's it for me, and I will hand it over to my colleague, Miranda Smith.
Thanks, Peter. And next slide, please. As Peter mentioned, I'm Dr. Miranda Smith. I cover the Asia Pacific office for OGA. So that is spanning from the western border of India to the western border of the US. So it's quite a large portfolio, but today I'll be covering APEC and ASEAN specifically, which are two groupings within that region that hold a lot of promise, I think, on their AMR work. And I really want to highlight where we, the US, have partnered with those multilateral functions to push our AMR progress. So I will start with APEC, which is the Asia Pacific Economic Cooperation. You may have seen APEC arise in the news quite a bit lately. So the US hosted APEC this year. So President Biden participated in those final meetings for that just last month in California. So APEC is an interesting grouping of economies, not countries, but economies. And that is because we include within APEC, Hong Kong, China, Chinese Taipei or Taiwan. And then we've got some other members that can potentially be a little contentious. So we've got Russia and then the People's Republic of China as well that are members. And then some members that, you know, my office, as far as the Asia Pacific office, doesn't work with as much. So maybe Peru and Chile, we wouldn't typically engage with, but within APEC, we do get to engage with those folks. So a really interesting grouping of countries on both sides of the Pacific. And we have been able to be engaged within APEC in the health space since 2007. So similar to G7, G20, there is a health track for APEC. There are many other tracks because it does cover economic cooperation. And as we know, that can include many, many things. So the health track specifically looks at health-related threats to the economy and trade for the member economies. So with that, next slide, please. I just want to cover specifically the AMR work that has really gone on within the health working group and further into the high-level meeting on health and the economy, which was chaired by Secretary Becerra, as you see pictured here, in August in Seattle. So I will touch on that a little bit, but APEC is really unique in that because it focuses on the economy, it also includes the private sector. So we have government partners that are there representing the economies that I mentioned before, but we also have several industry partners. We also have academia present. There are really no limits on who is able to interact in this space. So we are able to get a lot of discussions going that maybe we wouldn't normally have because, you know, it's more scripted. A lot of these high-level ministerial meetings are very scripted, and we're unable to really further our agenda as we would like to. But being able to bring the public-private partnerships really into the forefront has enabled us to get a lot of projects either underway or actually completed. So since 2008, we've done 14 projects focusing on AMR specifically within 3 forums. So not just the health working group, but within other working groups within APEC. So that may include other ministries or departments which normally wouldn't work in the AMR space as much. We attempted to really make AMR one of our focus efforts during our U.S. host year this past year for 2023. So the biggest piece of that was actually a 2-day workshop that we were able to conduct during the senior officials meeting, which I mentioned in August in Seattle. So within that, our project basically was a year-long project conducting information gathering across the APEC economies. And really what we were looking at was that global efforts, as we've seen, and as Peter had mentioned with G7, G20, global efforts to incentivize antimicrobial R&D have succeeded somewhat. There's been some new drugs that have gotten approved. Developing and really promoting the development of antimicrobials has been kind of a mixed bag. But then, of course, we have issues with maintaining responsible stewardship. And of course, within APEC, that is certainly a challenge within the economies. But APEC also offers a really unique opportunity to address the issues from the smallest countries like Papua New Guinea, or to high-income countries that are really kind of at the forefront of leading on some of these efforts. So like the US, we really try to be an example. So for this workshop, we joined governments, private sector, non-government stakeholders. And basically our focus was to align key priorities related to incentives, financial incentives for antimicrobials within the APEC economy markets. So we ended up having nearly 50 participants covering 8 total economies. And so about half of those were private sector and the other half were government participants. So we began, as I mentioned, it was about a year-long process. We began by surveying the APEC economies on their existing strategies and best practices, what they may be doing as far as providing economic incentives for antimicrobial production, and what kind of barriers and challenges they were seeing for market entry for new drugs in their own economy space. So we weren't really looking at the global kind of cohesive picture. We were looking at those individual economies and trying to see and pinpoint what each one was kind of dealing with in their own borders. So really the goal of the workshop, fully was to enable those APEC economies to identify and create practical, regional, and economy-based incentive strategies to support their AMR efforts, market entry and access. So we have developed a final paper basically outlaying various options within the region that is currently pending publication. So it should be, we're hoping, published on the APEC website by the end of the year. So of course, would be happy to share that. And we were able to get AMR included in the chair's statement by Secretary Becerra. So the last time that had happened was 2017 in Vietnam. So it had been some time since we really focused on the economic impact of AMR, especially in a lot of these lower middle income countries that are part of the APEC work. Next slide, please. And moving on to ASEAN, the Association of Southeast Asian Nations. I will say the US is not a member of ASEAN, but we are frequently invited by the ASEAN member states, which are listed there, to participate, to act as a partner within various forums. Again, very similar to G7, G20, and APEC, there is a health stream within ASEAN. So ASEAN will have other partners that they work with as well. So you may see ASEAN +1, ASEAN +3. It just kind of depends on who they may be partnering with at that point in time. But as you can see by the member states that are represented, and you may identify their a country such as Burma, which is undergoing a coup, has a lot of migration with that, a lot of conflict with that. So we see a lot of challenges and issues with addressing AMR in some of these countries. Again, a lot of lower middle income countries, and then countries that are a bit more advanced, a bit more forward leaning, especially Indonesia or Thailand, that are really trying to address AMR and are more able to do so. So really an interesting mix of member states within ASEAN. Next slide, please. And to just briefly touch on some of the work that has been done within ASEAN, we had done with ASEAN kind of, again, as an observer, as a supporter, really kind of push the ASEAN leaders to make a declaration to combat AMR. And again, this was in 2017, so it's been some time. I would note that since the Biden administration, the U.S. has really taken a more active role in engaging with ASEAN, especially within health cooperation. So in 2021, the U.S. put in, I think it was just over $40 million towards efforts in the U.S. ASEAN Health Futures Initiative. So that really accelerated research, strengthened health capacity, and developed healthcare workers so that we could address challenges like AMR. But again, there is still work to be done. In 2019, we assisted again with kind of giving our input in addressing the ASEAN strategic framework to combat AMR through a One Health approach. So within these countries, and especially a lot of the Pacific region, the One Health approach is really, really a large focus, given the challenges of climate change, environmental health. They do have challenges such as wet markets, livestock markets that they are trying to really address through the One Health approach. But all of those things, again, contribute to AMR and contribute to that high rate of AMR in the area. So regardless, the strategic framework mission is to really formulate and implement a structured regional plan across the ASEAN nations, adopting that One Health approach, committing to adopting the One Health approach. So basically, they will do that through comprehensive, multi-sectoral, multidisciplinary engagement, including participation of all governments of the member states and various stakeholders. So not just governments, but also, again, private sector, academia, et cetera. And then just last year, we were really excited about this rapid assessment. So basically, this was a study that ASEAN undertook to look at an understanding of regulatory mechanisms on antimicrobials in the ASEAN member states, which, again, there are a lot of challenges around the regulatory side of things. Many of these nations have very few requirements on how you obtain antimicrobials. So you can walk into a pharmacy and buy something off the shelf if you want. And that does add, of course, to the rate of AMR that we see in those countries. So this assessment was really done to collate that information on regulatory measures to see how we can better control and monitor the use and sale of antimicrobials. So we really acted as an advisor to kind of assist with that rapid assessment. So with that, it was published and is basically, again, very much a comprehensive kind of snapshot of what the current regulatory measures are in the region. While there is, again, still work to be done to assess those current challenges and gaps that we saw within that assessment, it certainly offers opportunities for us to continue engaging in this space. So certainly within APEC, within ASEAN, there are multiple measures that provide an opportunity for us to continue working on AMR, to continue engaging with our international partners, and really act as a leader in this space. And I think that's my last slide. Maybe. Yes, it is. So with that, I will turn it back over.
Great. Thank you. Thank you all for the great presentations and the clear presentations for us. So now we'll have council discussion that'll be moderated by Sarah McClellan. For the council members, please indicate that if you have a question by raising your hand. As we wait, I'll ask. I have a number, but I'll only ask one. This is an interesting topic as we think through all of this, and I guess for me, in preparation for these different meetings, whether it's the G7, G20, or it's UNGA, right, the United Nations General Assembly meeting, how do you all collaborate across departments, like Department of State, Department of Defense, these sorts of things? And that anybody can take that, whoever feels most or feels best to answer.
So I can start on that, and maybe my colleagues will want to pitch in as well. We have institutionalized relationships in place for all of these different fora, initiatives, mechanisms. Specifically on AMR, though, that initial executive order did set up that international working group. And that is a regular touch base between HHS, USDA, and State Department, but it is a whole of government approach as well. We bring in the other agencies as needed. We work with EPA and VA and GAO, and I'm throwing a lot of acronyms at you, but basically all the different US government partners. We reach out to them, we send out declarations and resolutions, but we also call together informal groups so that we can discuss what the hot topics are, pick up any concerns that the interagency might have, and then also figure out what the priorities are that we need to go out and advocate for and really push. OGA's role in that is often figuring out what part of this very complex multi-sectoral problem belongs in which group. So some of them are more technically focused, some of them are more politically focused, and we can help sort of thread that needle for the interagency when it comes to health topics. We talk to USDA and state every other week. Those do get rescheduled around the holidays, but we touch base on a regular basis so that we can compare notes in the G7, as Peter mentioned. We can talk about trade concerns or financial concerns. We have less frequent touch bases with our econ agencies such as Treasury and Commerce, but we do engage with them as well. So we have the point of contact in the task force, have multilateral point of contacts that we use for things like WHO, PAHO, etc.
Great, thanks. We'll go with Dr. Marks next, and then Dr. Plummer.
Thank you. What a rich start to the meeting, so thank you for that. I think our friends in OGA have clearly outlined multiple themes, but two that come to mind: the global connectivity and the need for collaboration. And then Dr. Shamus, in the patient perspective, brought up two other major areas. Not that AMR is not massive in and of itself, but she also brought out the themes of healthcare-associated infections as well as sepsis. So maybe Dr. Philby, are we, since many countries don't have the resources that we do, are we helping optimally to connect these other major themes rather than trying to have them, individual silos? What are we doing to help co-advocacy and actions across that greater landscape that's important to AMR?
I think this is a question that CDC can also feel free to dive into this afternoon because they lead on a lot of this work as well. But to answer your question, they are technically siloed, but they're not. So for example, WHO has an IPC framework as well that we have experts from each. We make sure that we have experts from each working together so that we're getting the perspectives of IPC and wider than IPC, prevention and other areas into our AMR work and vice versa. So we do try really hard to make sure that we have our experts engaged with all the different global advocates and initiatives that work on this area. And I understand my internet is lagging a little bit, so please let me know if I need to repeat any of that. But we acknowledge that sepsis and IPC are critical parts of AMR, and we are connecting them together.
Thank you.
All right, thank you to all of our speakers from OGA. Appreciate the insights, and I think it was really clear, kind of across the different forums, whether it's UN or G7, G20, APEC, that leadership or presidencies of the G7 and G20 change, and those really get the opportunity to drive agenda. And in others like APEC, there's host. We just completed hosting for that. I was curious for some insights, if any of y'all can provide them. Obviously, UNGA 24 is a big focus of an opportunity we have to kind of push some, potentially advocate for some action in this area on the global stage. I would assume that there may be some of these other fora where, because of impending presidencies or something, we might also have some more opportunity. And I wasn't entirely clear if there's any of those fora where we might have a stronger opportunity to advocate in that fora, and as such might be an opportunity in a PACCARB recommendations to provide some insight in how to interact, or recommendations on how to interact in that opportunity.
Maybe I'll jump in here. So G7, G20, I mean, definitely we're at the start of both of the 2024 presidencies. So we do have an ability to really propose things and see where that goes. And I'm pretty sure, there's the topic of One Health has become very prominent now. And I think one thing that presidencies have done and probably will continue to do is host side events. For example, a high-level side meeting on One Health or on AMR. That could be something that's done that produces its own outcome document that really is a deeper dive into the topic than the broader ministerial declaration. And if we're really looking into the future, the United States holds the G20 presidency in 2026, and then the G7 presidency in 2027. So if we're really going to be forward-looking, we have an opportunity as the coming presidency to really tee things up and make a very prominent agenda item.
I would just add on to what Peter said. Our hope, I think, within APEC at least, is to develop something similar, or to encourage the development of something similar to TAPFAR, where we have a Trans-Pacific task force on AMR. So that is something, for the US, we really want to promote, but not necessarily be the primary lead. I think we've encouraged our friends in Japan to perhaps take up that mantle and really kind of get some of that engagement going. So that is our hope for the future moving forward, is to work on those collaborations. I think as far as keeping momentum going from our APEC host year, we have engaged already with Peru, who will be hosting in 2024, about carrying forward work specifically in AMR, and they're very interested in that. So our hope is to continue with the workshops and engagement with a lot of the technical experts and a lot of the industry partners that we have in that space. So really keeping those public-private partnerships going. Over.
And just to add a little bit more to that, we have groups that we're continuously engaging with. So for example, Assistant Secretary Lois Pace, we've already mentioned, always co-chairs TAPFAR. And that's a partnership between us, the EU, Canada, Norway, and the UK. And it's meant to collaborate and coordinate on a more technical level, but it does do some policy discussion as well. So there are opportunities there. And then also the US is not currently leading. We had our chairmanship a couple of years ago, but we're heavily involved in the Global Health Security AMR Action Package. And we're involved in a lot of other action packages under the Global Health Security Agenda as well, such as legal preparedness, where we talk about legislation, executive orders, regulations, all the different mechanisms possible to countries to look for ways to implement the actions we want. There's laboratory capacity building action package, where we can do more on surveillance that's not completely focused on AMR. But there's a lot of action packages where we can look for overlap, and we do. And there might be opportunities for the US to do more if there are specific topics that either advance AMR or that AMR can advance.
Thank you. Real quickly, we have time for one more question. So Dr. Patel, you can take it if it's quick. Unfortunately, Lucas, we won't have time for your question, but we will engage our OGA colleagues down the line as well.
Thank you. Thank you to all the speakers. This was really helpful. My question is for Gabrielle Lemorel. you provided outcomes data, and I think that's just wonderful. I know that you highlighted that there was mixed progress from the 2016 UNGA planning. Do you think that was related to COVID-19? And how can better progress be ensured from the 2024 event?
Thank you for that. And I think it can be a challenge with a high level declaration at a high level, like you have in a UN General Assembly political declaration. There's a lot of factors that go, as I mentioned, that go into the final language, and it is ultimately a political document. So it's not in and of itself a global action plan. I think they're sort of in dialogue with one another. So the data, some of the data might look a little bit different if you looked at implementation of a national action plan, but I think in terms of having effective political declarations, so you are more likely to be able to track progress coming out of it if you have more specific information in it. So a lot of the declarations don't have, they have aspirational statements about supporting and encouraging work in certain areas, and that's very critical to bring partners on board who might be uncomfortable with a very specific hard number. But it also is there by nature much harder to assess what has happened as a result. So that's part of the conversation that's happening across all levels among WHO member states, among those who are being convened by the Global Leaders Group on AMR and other discussions. What's that sweet spot in order to define targets that we can actually measure that will drive action, but that are not, but that are flexible enough that countries that they'll speak to and be in countries at many, many different levels of involvement and development can take them up. So that's part of our art in multilateralism, as Peter and Miranda and others can attest to. I think it's important to see how these things are in dialogue with the more technical work that happens at WHO, FAO, UNEP, that happens with other partners and in other constellations. So looking how we go, how the declarations can help accelerate momentum and progress and drive more specific action in each of those sectors and across them.
Thanks. Thank you all to our presenters from OGA. We really appreciate you being with us today and providing really great content and context for our task. Dr. Newland?
Great. Yeah, thank you again to our OGA colleagues, and have a wonderful holiday. Thank you also, Council, for the questions. Lucas, sorry, we'll make sure you're up there. I won't take a question. All right, so let's move on. Next, we're going to transition now to hear from Dr. Clara Davis and hear about the activities of the Department of State Bureau of Global Health Security and Diplomacy. Welcome, Dr. Davis, and it's the virtual floor is yours.
Great, thank you very much. And thank you for inviting me to present on State Department's work on AMR today. And I apologize a little bit for my voice. I've been fighting a cold for the last few days. So if I take a coughing break, I'll promise to try to mute myself. If we could go to the next slide, please. So states' role on antimicrobial resistance is part of our broader role in global health, and global health is part of our foreign policy priorities. Obviously, as we've all come out of the COVID-19 pandemic, we're seeing why this is so integrated with foreign policy. Disease threats in one country are a threat to all countries. The infectious diseases, including drug-resistant ones, don't respect international borders, as we know. And the US leadership on the diplomatic fronts is critical to enabling effective global and regional coordination to prevent outbreaks and to respond to them. Additionally, the US invests more than $12 billion annually in health assistance around the globe. And this is an important part of both our foreign assistance, meeting our goals of improving health globally, but also part of our relationships with other countries. Next slide, please. So as part of this priority, this past August 1st, Secretary Blinken launched a new bureau, the Bureau for Global Health Security and Diplomacy, which is headed by Ambassador John Kingasong. Now, prior to this, health issues at the State Department were housed in a variety of different offices. So what Secretary Blinken has done with this is bring all these pieces together. So we've merged the President's Emergency Plan for AIDS relief, the outbreak response functions, including the COVID coordinator's office that was stood up in response to the COVID pandemic, health diplomacy, global health security, and our participation in multilateral bodies such as the WHO, all to be under one organization within the broader State Department. Next slide, please. Now, the mission for the new Bureau is to lead the U.S. diplomatic engagement and support our programmatic efficiency from across the interagency in preventing, detecting, controlling, and responding to infectious diseases, and to leverage and help coordinate U.S. foreign assistance across the globe on health, and elevate and integrate global health security as a core component of U.S. national security and foreign policy. Next slide, please. The priorities of this new Bureau are, first, to finish the fight against HIV/AIDS. PEPFAR has been a 20-year bipartisan effort, which is focused on a single disease, but has also led to benefits in research, health supply chain, and stronger health systems in the countries in which it's worked. The second is to transition the structures that were created during COVID-19. We know that additional outbreaks are going to occur, and the better prepared we are with the relationships in existence and the channels of communication, the better our shared global response can be to the next outbreak. The third is to improve the capabilities of the national and regional institutions to prevent, detect, and respond to outbreaks. Fourth is to strengthen the global health security architecture. And then the fifth is to empower the department and its workforce to lead. This is part of the Secretary's modernization agenda to ensure that our department has the knowledge to work on these issues in collaboration with our interagency. Next slide, please. So how does the State Department work on these kinds of issues? We're not a technical agency. We're not funding research. We're not regulatory. We're not working on clinical recommendations or running labs. A lot of diplomacy is about creating and maintaining relationships. So our role is primarily a coordinating role. We know that coordination across the U.S. interagency is critical to strengthening health security. And so our role is often to collaborate with the U.S. technical agencies, coordinate the technical work, and incorporate it into our broader foreign policy and our relationships with other countries. Next slide, please. Part of how we do this is through our global presence. We have over 270 diplomatic missions across the globe, staff of almost 25,000 foreign and civil service, plus 45,000 locally employed staff. At many of these posts, we also have the U.S. technical agencies with permanent assignments. For instance, CDC has offices abroad. The USDA has the Foreign Agriculture Service and APHIS housed within our missions. USAID has technical experts running development programs. We have the health attachés that were mentioned during the OGA presentation. Separately, we also have the other technical agencies ranging from Department of Defense, NOAA, Department of Commerce, Fish and Wildlife, et cetera, depending on the needs. There can be a pretty substantial U.S. interagency presence at any number one of our diplomatic missions. And on the ground, we work closely with all of these U.S. technical agencies in areas such as human health, agriculture, tourism, trade, et cetera. Next slide, please. Because of our global presence, the State Department officers overseas play an important role in collecting the information needed back here in DC to shape policy. For instance, with this slide kind of outlines how when an outbreak occurs, we can put out a request for information to all of our offices within other countries, asking for specifically what data is needed. They can then kind of collect the same type of data across all of our embassies, send back to Washington, where we can collate, analyze, and organize that data, present to policymakers, have the decisions made in DC of what we can do, say, on foreign assistance to assist with an outbreak, and then transmit that back to embassies who can then work with the host governments in terms of how we can work together, how we can assist, etc. This slide was designed specifically around outbreaks, but this is relevant, this kind of how we collect information, feed back and forth, and how that process is iterative is relevant to any number of areas within the health sphere especially, but any number of areas. And next slide, please. I know I don't need to convince this group that antimicrobial resistance is a serious health threat. Ambassador Kingason recently identified it as one of the greatest health security threats in his priorities. And why we integrate at state the antimicrobial resistant work into our broad health security work, rather than say the single disease type work we do on individual outbreaks. I mean, obviously, antimicrobial resistance isn't a single disease. It also does not affect a single country easily crossing international borders. Fundamentally, it's an evolutionary problem. We can't just solve this problem once. We need to be solving it in a broader setting, crosses many technical and economic sectors. The knowledge gaps are global, especially in the lower middle income countries. And some of the tools are very specific to AMR, such as some of the discussions of economic incentives that are needed for development of new medications, encouraging stewardship, etc., specific AMR education. But many of the tools we need that have already come up, infection prevention and control, water sanitation and hygiene in health facilities, vaccination, these are all fundamental to basic health system strengthening. These are part of the broader picture that not only is part of dealing with antimicrobial resistance, but other infectious diseases also. Next slide, please. So some of the areas in which state can play a role in antimicrobial resistance is raising awareness among the actors who aren't necessarily working in the health space. That can include within our own department, in addition to our counterparts in other countries, identifying the links to other fields and bringing these groups together on these issues, working with the US interagency as part of our overall coordination for the US presence overseas, and also coordinating multisectorally, both within the US interagency, but also working with multisectoral actors overseas. And of course, the multilateral negotiations. This is an area where we work very closely with the technical agencies, and I think HHS OGA gave a really good overview of that. For example, the G7 and G20 work, the work within the WHO, etc. And these are areas where we always coordinate very, very closely with technical agencies. And next slide, please. Part of our role is to bridge boundaries. And so I just wanted to point out 3 different types of boundaries that the State Department bridges in our work: the national, ministerial, and sectoral. National, of course, our primary role is bridging the boundaries to other countries and maintaining that relationship. So that includes those bilateral relationships, also multilateral relationships, and regional. That's not only important for the relationships and the actions by countries or regional bodies, but also because an issue such as antimicrobial resistance doesn't follow national boundaries, can cross natural ecosystems such as bodies of water, but also social ecosystems. This can be important when we're talking about issues such as travel and trade. Ministerial boundaries. In general, a technical ministry will usually have as their primary counterpart the equivalent technical ministry in that country. The State Department maintains relationships with all the ministries, not only health, but agriculture, environment, finance, tourism, etc. And this is critical to the whole of government approach that is needed to combat issues such as antimicrobial resistance. Third is sectoral boundaries. This is especially seen in many of our programs that focus on people-to-people exchanges. This can engage a wide variety of people from a wide variety of sectors, both from the US and from other countries. Next slide, please. And so I thought I'd wrap up with just a few examples of some areas where we've been able to incorporate antimicrobial resistance into our other programming. The first is our engagements with government officials. This can be specific meetings or trainings. The photo on that one is a project we did where we collaborated with Singapore to do a training for government officials within Southeast Asia. We have been able to organize 2 of these so far, specific to antimicrobial resistance. We've also organized several that are One Health focused, so that AMR is not necessarily the exclusive focus, but is one of the topics that we bring into that. We also regularly, and with these kinds of programs, we both can go out and run them in country to work with government officials. We also have specific programs to bring government officials elsewhere from other countries into the US. And that can involve meeting with our technical federal agencies, but also gives the opportunity that we think is really important to meet with some of our state and local agencies, especially departments of health also, so that we have the opportunity to exchange information and have both sides learn from each other. Second area is multi-sectoral outreach, especially in coordination with various US technical agencies. The photo shown is one from a workshop we recently organized jointly with the National Science Foundation. This was aimed at bringing researchers from different sectors together to encourage developing research proposals that are multidisciplinary and multiple sectoral, specifically focusing on One Health. So again, broadly One Health, but AMR is one of the topics we discuss multiple times, and we may make a point of bringing in AMR researchers into this kind of workshop because it's an opportunity for them to reach out to other sectors. And we've done one of these workshops this past year in Africa and one in Southeast Asia. And then one of our major programs is our people-to-people exchanges. This is a really, really broad area. This can include bringing foreign nationals to the US as part of exchange programs, but also bringing US students, US experts to other countries. And these programs have included scientists, artists, youth programs. This can cover any number of topics. This photo is specifically from our Science Envoy program. This is a case where we work with distinguished US scientists to reach out to scientists and students in other countries. And with the next slide, please, I believe that's the last one. With that, I'd like to thank you for your attention today and look forward to the council's discussion. Thank you.
Great. Thanks, Dr. Davis. Fantastic. A lot of great stuff there to learn about the State Department. Definitely now we'll open it up to questions, and I'll turn it over to Sarah for moderating.
Great. Thanks, Dr. Newland. Dr. Sinchak.
Hi, thank you so much for that excellent presentation. I was particularly interested on your slide that depicted the flow of data to diplomacy. And because we know that a lot of the work that we do as part of the council is about sort of measuring and capturing the problem using various data sources and communicating those data. I'm just curious if you can talk about how well that works and if you see any areas of specific challenges relating to getting data, analyzing the data, communicating the data. I know that's a big question, but I think that's a really important part of what we do in thinking about AMR. Thank you.
Thank you. Really good point. And I think part of, we created that slide during the mpox outbreak as we were trying to make decisions back here in DC about how to assist other countries who were asking for help. And one of the issues with data is often they are not kept to the same standard, right? Each country is reporting things in their own way. So even when we collect what they've put out, sometimes you're not comparing apples to apples, right? So what we did in that case was we went to our officers overseas and said, okay, we need to have kind of the same data to compare back in DC. Please go to the health ministries, ask this set of questions. Here is what we need answers to. And again, one of the things we've got now, if we've got, say, CDC in country, we might be able to get a lot of information from, say, CDC. But in many of these cases, we don't necessarily have CDC present in every country. So we're going to officers who are not necessarily health experts. So what we created in that case was saying, here are things that people who are not specialists in this field, questions they can ask, what is the information we need, help them shape that. And then they could go to the health ministries, ask very specific questions about, what was available in country, what were they seeing, what did they need us to do, etc., and bring that back. And being able to bring that back so that when we put out a call to all of our embassies saying, here is what we need, it needs to be these questions and the answers in this format, we bring it back to us and we can suddenly actually be making a legitimate comparison that makes it much easier for us to actually understand what's going on without trying to adjust for differences between countries or how reporting's done. So this is a case where we can help with that problem.
Thanks. Dr. Newland.
Yeah, thanks for that answer. It's as I'm hearing you talk more and more, I feel like I'm learning more. The role the State Department has in this is a lot greater than I ever realized. And even seeing on your slides the PEPFAR logo in the corner, I'm like, oh wait, this is the State Department's work. And many would argue, or I would argue, it's one of the greatest accomplishments of what we have done as a country, as a world, really, in working toward HIV and help treat HIV and some of those. And then I think at TATFAR, which obviously has something that's not necessarily in the State Department. So there's obviously a lot of moving. So I guess question is how do we leverage like some of the successes of PEPFAR across that the State Department led to help us more with TATFAR? Now, I think it's a whole another complex issue, and TATFAR is obviously larger, but anyhow, any thoughts to that?
So this has been a discussion. I mean, one of the things that came about during COVID was being able to try to look back and capture how our investments that were not always designed for the purpose of a new respiratory disease outbreak actually helped countries respond. So this is something we have been trying to kind of capture some of these successes and the lessons learned about how to continue to always improve. But I think we have seen it. Again, PEPFAR has done amazing health system strengthening aside from combating HIV infections. And that is linking to things that are related to AMR, that for a health facility to have proper hygiene facilities, etc., and clean water. That the fact that these are all integrated, and that's one of the things we are trying to do in general with our approaches to health security, is look at where are these closely integrated, and how do our investments in one area leverage our needs in other areas, because they're not independent. Health systems are often closely, different aspects are linked closely together. So I fully agree with you. I think there's a lot to apply, and I think we are continuing to figure out how to do that.
Thank you.
Dr. Plummer, and then Dr. Dixon, you'll have the last question as we're coming up to time.
All right, thank you. Appreciate the presentation. I wanted to follow up on your kind of comments about asking for specific data. I think normalization of data and consistent data is a problem we face across AMR and a lot of other places. But at least in some of our efforts, we say, here's specific questions, and we either get told we don't have access to that data, we don't know those specific answers, or we get data that sometimes may or may not be accurate because they don't have access, but they feel obligated to provide data back. And so I was just curious, and that's just kind of on a local scale, in state or national. On that global scale, how have you been able to track and verify much of that data, or how comfortable do you feel when it's not something they're routinely tracking and you're asking for a different data point, that they're giving you accurate data back that really is comparable?
I think that's always a good question. And I think, I don't think there's a single answer. I think it's going to very much depend on what you're asking, and has it been tracked before or not? And it is obviously, as we keep kind of coming back to, it's a good argument for some of these, shared agreements on what things mean. And it's why some of these settings and some of these multilateral conversations are so important, is that they are an opportunity often to agree on what words mean, what should be measured, what data might need to be collected, etc. Though that is often a place where we can get multiple countries to agree to it, and that is always critical. And in terms of specifics, it's going to very much, unfortunately, depend on the specific question, I think.
Thank you, Tim, and then we'll close with Dennis.
Great, thank you very much. So what is the perspective from the State Department on the intersection between the global health security agenda and the food security agenda? One can imagine that engagement with both bilaterally and multilaterally, that you see that there are a lot of areas where there's overlap and opportunities for advancing things, but also areas for tension and a need for resolving opposing views or needs. So if you could comment on that, please. Thank you very much.
So our bureau works closely. We have a separate office for food security issues at the State Department. So whenever we intersect, we always work closely with them, just as we work closely with the other parts of the department. We have a separate bureau that's economic issues. So whenever, say, health issues are hitting health supply chains, for instance, we don't keep that solely within the health bureau. We work very, very closely with our economics bureau, just looking at supply chains issues. So we work with them, and then the food security bureau whenever we're hitting an intersection. And if that means then working with the interagency to kind of figure out where we hit the spot between all the different issues. But we do have internally within the State Department offices that focus on all the specific issues.
Dennis?
Oh, thank you. So I just want to point out some history and a little bit of clarification and expansion on Dr. Newland's use of PEPFAR and TADFAR in the same sentence. So those are separate but similar entities. And I can speak to this because I proposed the name TADFAR as one of the first members of TADFAR when it was a presidential declaration in 2009. And we were struggling to work on what we were supposed to do because a declaration from the president means you have to do it. And what should we call it? And so I did this in tribute in part to Dr. Fauci because of his connections and hard work to PEPFAR and AIDS, and in part because of name recognition value. I said, well, we got the letters, it's transatlantic, it's a task force, and it's focused on AR, so it's like a no-brainer. It should be called TADFAR because people have heard of PEPFAR. So thank you for picking up on the sound value of that. And just a clarification on, they're a little bit different, and we would like for TADFAR to reach the acclaim of PEPFAR at some point.
Thanks for that comment, and thank you, Clara, for your presentation. Dr. Newland, back to you.
Yeah, great. Yeah, thanks, Dennis, for that. It worked well, very well. So thank you. And then Dr. Davis, yeah, I really appreciate you. Hope you feel better. Hope you have a wonderful holiday. And thanks again for the great presentation and the council again for the discussion. All right, so let's move to our last speaker for this morning. It's going to be Dr. Jessica Petrillo, who will be speaking about the U.S. Agency for International Development, or USAID. So welcome, Dr. Petrillo.
Thank you. Thank you to the Council for taking on the task of exploring how to improve global capacity to address AMR, and for the opportunity to speak with you today. I'll use my brief time to provide an introduction to USAID's approach and end with a few points I hope will help inform the Council's efforts on this task. Next slide. Antimicrobial resistance threatens the health, resilience, and stability and prosperity of communities and nations. Next slide. The global capacity to address AMR is low. However, countries have made significant progress since the release of the WHO Global Action Plan on AMR in 2015. Over the past 10 years, countries with which we partner, many of the least developed countries, have mostly been at the initial stages of capacity strengthening, assessment, coordination, and planning. This includes developing initial national action plans, establishing multi-sectoral coordination bodies, assessing capacities, and developing associated SOPs, and strengthening capacities in individual facilities. Looking forward, it's important that we understand and build on these improvements. As an example, Cameroon had no AMR surveillance program prior to the initiation in 2020 of USAID's assistance through the Infectious Disease Detection and Surveillance Program, IDDS. After assessing the capacity of 35 microbiology laboratories for AMR detection and surveillance, IDDS helped to establish and provided mentorship to 10 Sentinel surveillance sites. IDDS also facilitated the review and validation of national documents, guidelines, and SOPs to enhance detection of priority AMR pathogens. By 2021, Cameroon collected and screened 18,000 human specimens with over 1,500 AMR pathogens isolated, and over 1,200 samples from various animal species with over 2,000 AMR pathogens isolated. Cameroon is now reporting AMR data into the WHO Global Antimicrobial Resistance and Use Surveillance System, GLASS, a significant milestone reflecting the high quality of newly available bacteriology services and of AMR data. Next slide. USAID is the United States government's lead for international development and disaster assistance. For more than 60 years, USAID has partnered with countries around the world to improve health and economic prosperity, saving lives and protecting people, communities, and countries most vulnerable to the health, economic, and security impacts of infectious disease. As a multi-sectoral development agency, USAID is well positioned to promote a sustainable, One Health approach to strengthening the health ecosystem to address the emergence, spread, and impact of AMR. We partner with governments, local actors, NGOs, international organizations, private sector, and civil society to strengthen health security and health systems. This includes public, animal, and plant health, recognizing that the factors that contribute to AMR can only be addressed through integrated efforts. We take an agency-wide approach to AMR, partnering to improve capacity in low and lower middle income countries through activities in TB, malaria, HIV, maternal child health, water sanitation and hygiene, and sanitary animal production, pharmaceutical systems, innovation, humanitarian disaster assistance, and global health security. Next slide. We have three main spheres of influence: direct and catalytic investment, advocacy. This includes leveraging technical expertise, informing policy, and strengthening global architecture. And third, fostering innovation and research. We leverage these three spheres to strengthen local, national, and global capacity. Specifically, we invest in strengthening governance, prevention and control, including IPC in health care facilities, in effective water, sanitation and hygiene in health and community settings, vaccination and good health management and hygiene practices in animal production and along the value chains, AMR surveillance and diagnosis, including diagnostic tools and laboratory capacity, reagent supply chain, knowledge management, human resources, reporting of AMR data and integration of data across sectors, optimized use of antimicrobials, including reliable and quality assured pharmaceutical supply chains, antimicrobial stewardship, practices in human and animal health and case management, awareness raising, social and behavior change, and risk communication, including in training healthcare and veterinary professionals and public outreach and education efforts, S&T and R&D, including basic and applied research in vaccine and therapeutics development, treatment regimens, and best practices in infection prevention and control and antimicrobial stewardship in human and animal health and the agri-food value chain. Over the following slides, I will provide a brief overview of four major lines of effort that demonstrate USAID's AMR work. Next slide. Tuberculosis is the world's deadliest infection. TB is curable, and the global community is making significant progress in detecting, accurately diagnosing, and treating the disease. However, the emergence and spread of drug-resistant TB threatens realization of the goal set by the global community to end TB by 2030. For more than 20 years, USAID has been a global leader in the fight against TB and has led the USG response to the global TB epidemic. The agency supports bilateral programs in 24 priority countries and provides technical assistance to additional 31 on a wide range of areas, from improving diagnosis and treatment for both drug-sensitive and drug-resistant TB to strengthening service delivery, helping to ensure person-centered care. USAID strategies to prevent the development and spread of drug-resistant disease are supported by a robust TB portfolio that includes introduction and expansion of new, more rapid and accurate diagnostics for TB and drug-resistant TB, the development and use of shorter, less toxic, and more affordable curative treatment regimens using new and existing medications, clinical studies, operational and implementation research focused on gathering data and evidence on antibiotic stewardship through and support through patient-centered care. Next slide, please. Malaria is one of the most devastating infectious diseases. It is a leading cause of child mortality, killing about 500,000 children every year. While the progress to date is historic, resistance to artemisinin family of drug threatens the continued control and ultimate elimination of malaria. The U.S. President's Malaria Initiative, PMI, led by USAID and implemented together with CDC, works closely with national malaria programs in 27 countries in Africa and the Greater Mekong subregion, and with global partners to reduce the burden of malaria. USAID's investments through PMI address AMR, including in the areas of infection prevention and control, stewardship, strengthening service delivery, surveillance, including monitoring of anti-malarial efficacy and drug resistance, and R&D. Next slide, please. USAID is a global leader in maternal and child health. The efforts of the Office of Maternal and Child Health and Nutrition focus on 25 priority countries that together account for more than 2/3 of maternal and child deaths worldwide. It's projected that an estimated 11 million days of antibiotic use each year could be prevented if every child in the world received a vaccine to protect them from infection with Streptococcus pneumoniae bacteria. Through USAID's support to Gavi, the Vaccine Alliance, more than 215 million children in greater than 60 countries have received pneumococcal conjugate vaccine. USAID also strengthens the timely diagnosis and appropriate case management of possible severe bacterial infections, including pneumonia, in newborns and children in 25 countries. Research shows that 35% of healthcare facilities in low and middle income countries fail to offer soap and water for hand washing, and many more do not meet basic sanitary standards. USAID works with local governments and stakeholders to strengthen WASH systems in the household, community, and institution levels, including pioneering the Clean Clinic approach, a quality improvement strategy to strengthen WASH in healthcare facilities. Next slide, please. The USAID's Global Health Security Program works as part of a coordinated U.S. government effort to provide direct support to 50 countries and catalytic support to another 50 to achieve demonstrated capacity in 5 technical areas as measured by the WHO IHR monitoring and evaluation framework. AMR is one of the DHHS program priority technical areas. Our activity supports strengthening in multi-sectoral coordination on AMR, including the development and implementation of multi-sectoral national action plans on AMR and multi-sectoral coordination bodies, surveillance systems of AMR, including national AMR surveillance systems that integrate surveillance of AMR and pathogens of concern to human and animal health and agriculture, and infection prevention and control, including functioning IPC systems for healthcare facilities and sanitary animal production practices, and optimized use of antimicrobial medicines in human and animal health and agriculture. The Global Health Security Program promotes a One Health approach to AMR, including supporting AMR training in One Health University networks. We also lead U.S. government investments in and monitoring of international capacity to address AMR in agriculture and livestock, including through our longstanding partnership with FAO and our innovative partnership in private sector engagement with Transform. Our work with these partners ranges from supporting the use of tools such as the FAO assessment tool for laboratories and AMR surveillance systems to inform targeted work plans, to the design, implementation, and evaluation of the impact of behavior change interventions, to the development of harmonized standards for AMR and AMU surveillance in food-producing animals. Our support for innovation in applied research includes our partnership with the International Poultry Council, which has secured private sector support for antimicrobial use stewardship principles, covering 30% of global broiler production, an innovative public-private partnership with Cargill on applied research on market sustainable approaches for improving animal health, reducing the need for antimicrobials. And in the new year, USAID will launch the AMR Access and Stewardship Initiative, AMRASI. This is a joint USAID Emerging Threats Division and Center for Innovation Impact project. AMRASI is a feasibility study of a market-shaping approach that sustainably increases access to urgently needed diagnostics and antimicrobials using pooled procurement while concurrently promoting stewardship through outcomes-based financing interventions. Next slide, please. The next phase of global AMR work should prioritize targeted efforts to enable sustainable change at the local level. A few critical areas that are currently underrepresented in the global dialogue include catalyzing and facilitating local leadership to foster sustainable results, expanding the local actors who are actively engaged in the development and implementation of effective, locally relevant, sustainable, data-driven AMR solutions, investing in applied and operational research, including the scale-up of effective interventions to inform policies and enact data-driven solutions, better integrating social and behavior change sciences and practices at the individual and community level, including retail and service delivery sectors to improve effectiveness of AMR strategies. And finally, at the UNGA level, high-level meeting on AMR in 2016, it was critical to elevate AMR as a standalone health, economic, development, and security threat. As we look to UNGA 2024, it'll be critical to explore and promote opportunities to increase linkages with relevant efforts to amplify impact, maximize the efficiencies, and promote more comprehensive and informed efforts. We cannot lose a focus on AMR, but to ensure long-term action, it'll be critical that our AMR efforts are not pursued in a silo. Next slide, please. Thank you for the opportunity to present today, and I'm happy to answer any questions and look forward to continuing this dialogue. Thank you.
Great. Thank you, Dr. Petrillo. You all have done amazing work, and it warms my heart you're talking about vaccination plans and programs. I will turn it over to Sarah and let the questions begin.
Thanks, Dr. Newland. Dr. Whittam, you are first.
Great, thanks. Hey, thanks for a really nice and really informative presentation. You opened with by describing a successful program in Cameroon, which is great and the type of change that we need. But I was just wondering, what's the process by which a specific country or specific location gets that type of investment and support when no doubt there are other countries and other regions with similar need and could have similar impact?
Great, thank you. Yeah, that project was one that was done through our Global Health Security Program. And so that is through our Global Health Security Program, and actually with sort of all of our programs, we have sort of a priority set of countries that are relevant for the context in which we have the congressional funds to pursue. So let that be, TB has their priority countries related to sort of the TB burden and that sort of aspect. Our Global Health Security Program has also related to where we have the countries in terms of the global health security parameters that we have. And so some of that is, in part sort of elements related to sort of the agreement across the US government, but then also, as you may know, USAID has expanded to over 50 countries that we engage on global health security. Under the context of the global health security, in determining sort of which of the countries take on AMR as one of their technical areas, that is in consultation with the host government and where their interests lie, and then sort of developing the associated programs that direct specific technical areas. So that's sort of, we've got some of those kind of constraints, but also it's really, once we have those sort of broader kind of country-specific determinants based on the overall mission through which we have the congressional funding, then it's also very much a collaboration with the countries to identify the specific projects and areas of work.
Thank you. Dr. Kwan.
So Dr. Petrillo, thank you for an excellent talk. I certainly learned a lot. I think you highlight an incredibly non-trivial issue about the importance of working locally in order to affect this change. Can you provide a little bit more color in terms of how this is done or example and what this looks like?
Yeah, and I'll say, and thank you for this question. It is clearly a topic that USAID is very passionate about. It is one of our under administrator power. Has also localization has been a major focus. I'll say one area that sort of I think we touched on a bit is, we hear a lot of the dialogue of, the critical role of sort of, regulation or, a lot of these sort of high level governance documents, which are critical. But again, if you're looking also at sort of the countries that have the greatest space to go in terms of also having the basic capacities to address AMR, you really need to be able to have the interventions be adoptable at local level. And so some of that you saw in our discussion was a lot of the focus also on applied research. And we have a couple ways. One is, having local partners be very involved in identifying the interventions that work in their local setting, having ownership of those. And so it can also be like through one of our programs, it was developing, WhatsApp groups on IPC that were able to, communicate and support each other across small health facilities in a location. So some of it is really that working with partners for developing the local solutions, but then also sort of that broader issue of as we're looking at partnering, it's not just the information, but having it really, whether it be local capacity partners, so those that are actually able to, not just always sort of the high level partners, but also ones when we're looking at implementing that are actually locally based and help reinforce that local capacity to be able to also expand out, because what we've seen a lot is we've made progress on individual facilities, but a lot of where countries are looking at right now is expanding across regions. And so how do you actually have sort of local actors be involved in that expansion to be able to have more than just 3 facilities, in one region, but maybe the entire region of the country? Thanks.
Yes, you're up.
Yes, thanks for a great presentation. And I'm glad you mentioned behavioral and social change, because, a lot of times we forget about bringing those social and behavioral science under the One Health umbrella. And you mentioned behavioral change in the livestock industry in probably lower middle income countries. Can you maybe give us a little bit of an example how your agency works, in that area?
There are a few areas. We have a lot of close work with FAO and a lot of how you kind of train and get local communities that engage with in the agriculture setting, in the livestock value chain, how you kind of that social behavior change element is integrated as part of that sort of our FAO work as well. And then we have things like I mentioned with the Transform, where it's also doing the applied research on feed additives and what is that, and also I shouldn't say feed additives, how you actually handle feed to be able, and the handling of animals to be able to reduce infection and reduce the need for antimicrobials, and then the elements that also help incentivize those behaviors. So as we're looking at the social behavior chain, it's not just sort of the education, it's the also sort of that applied research about what are the interventions that are actually going to sustain the change, and then also the elements of sort of potential market-based aspects of incentivizing change. So it is a critical area, but as we flagged on this, I think, a lot of times when we see in the global dialogue on awareness raising, that aspect of really putting the work into the social behavior change, the applied research, the consolidating lessons learned, the scaling up of interventions that are effective, the adapting them for local settings is not typically part of kind of what we hear, whether that, kind of throughout almost every aspect that we have, let's say like in the global action plan on AMR, changing behavior is pretty much foundational to almost all of them, and we don't see that as represented. As I said, it is a place that we are investing, but we still see as underrepresented in the global dialogue.
Thank you, Dr. Shrikantay. Yep.
Thanks, Sarah, and thanks for a great talk, Jessica. I actually am going to try to sneak in 2 questions. So I was heartened, like Dr. Newland, to hear you mention vaccines as part of sort of your approach to considering AMR, and recognizing that, of course, USAID plays a broader role in global health, including vaccines that are, including working on immunizations. And so I wanted to understand how is the crosstalk between groups within USAID who are focused on AMR and those within USAID focused on immunizations? And is there that crosstalk to see that AMR is part of the priorities in both groups? And how does that translate to your discussions with country counterparts? And the second is, given that USAID is working in countries like Cameroon, who may not have a strong voice in fora like G7 and G20, how does USAID use your relationships with these countries to inform discussions on targets and priorities at the meetings like the high-level meetings?
Thank you. So I'll say a bureaucratic way that we have helped to improve sort of the coordination across is actually sort of in the person. A role that I've had is being a point person on antimicrobial resistance for the agency. And so what that does is it's not to, it doesn't have an impact on, sort of the congressional mandates, but what it is it's in person to try to be able to build the community, have us have a common voice, like being able to pull these sorts of presentations together and really be able to, is an illustrative example of that relationship, right? To really try to view that as, how do we as a USAID have an integrated, if not fully integrated, but sort of aware way of approaching the issue. And there's still plenty to continuously improve, because we also have at the mission level, there's all these different levels to be able to enhance that. But we, over the last 3 years, that's been a priority in terms of the work that I've done, and I think we've really built that sort of community of practice across the agency. Again, within the constraints that we also are very much the way that Congress has designated, it's within the missions that have been designated by Congress. To your second question, actually, just to finish up on that first one, but I do think, as we flagged as the last point, I think that that's going to be an area that, as a global community, is going to be important. Like, how do we enhance the linkages between AMR and other efforts, whether that be also like the pandemic prevention, preparedness, and response? There's a lot of ways in which AMR is actually maintaining the steady state capacity. We found with COVID that we were able to transition to outbreak response within weeks through one of our AMR partners, based on the all their investments in IPC. And they were able to very rapidly mobilize those communities targeted to COVID. And so it's just an illustrative example of, kind of what we've talked about. For your second question, I think that that's really an area where USAID has tremendous value add in the global dialogues. And we take commitment, and engaging in strengthening the global architecture seriously, because it is something that we bring, the 60 years of development work. We bring the day in and day out of working with also in the low and middle income countries on the actual realities of what does it take to strengthen the capacity. And so we do work with our partners, but we also take that as a responsibility when we engage as part of the US government and help inform US government positions, is bring to the US engagement in these, that our coordinated US engagement, that wealth of expertise on what is actually, feasible, what will help empower countries and help, enhance both the voices and the experience that we've gained from having all these communities as partners as we try to solve this problem, because it is really a partnership with our local governments, with our local facilities throughout the world. And so it's a partnership, and we try to bring what we learn from those partnerships to help inform the global architecture to be the most productive.
Thanks. In the interest of time, we'll just take the last two hands. Tim, the floor is yours, and then we'll close out with Dr. Zagman.
Great, thank you, and thank you very much, Jessica. It's so nice to see a number of practical solutions that are being supported by USAID, and really apropos, given the task letter to PACCARB to look at global addressing AMR from a global perspective. First, to comment that we can see that AMR is an issue that undermines efforts at having significant progress with the development agenda. And I think this is something that needs to be strongly recognized and baked into the approaches in terms of what needs to be done for development more broadly. So AMR needs to be central to that. My question to you, though, is building on Padmini's question, and that relates to this localization and what is relevant and important locally, and who is setting the priorities in the agenda from that local perspective, and how does USAID best reflect the priorities from a local perspective, but acting in the way that it has to from the US. Thank you.
Yeah, thank you. A priority that has been for the administrator is really strengthening that localization component. And it's also, really building off of sort of the co-creation to have it as ensuring that we have the capacity that's, where it addresses local needs in the way that actually has it so that it's capacity both in the design, in the leadership, all the way through. And so it's always been sort of the partnership aspect is a critical component of our programming. As noted, we do have overarching strategic priorities. I'll use the global health security one, where writ large, we are seeking to have countries achieve demonstrated capacity in 5 technical areas as related to the IHR monitoring and evaluation framework. And so that gives an architecture, right? Or if we're saying, ending TB, like we have these architectures, and then it's how you get to that ends up being sort of a co-creation. And we've recently launched a local GHS project, which is really embodies at its core, the focus is sort of the local approach to addressing this, and AMR will be one of the technical areas that's supported.
Thanks.
Thank you. Thank you very much. I'll try to keep it short. I know we're past the time. So I'm coming from the perspective of someone who works with numbers and risk analysis specifically, and USAID has made a tremendous impact in building capacity. Specifically, you showed examples of laboratory capacity building, reporting. I wonder if you could share some thoughts into how to measure the success, particularly in how that reflects into clinical success. For example, reduction in resistant infections, and very importantly, treatment failures, and how we compare that across countries that you're involved with, which might have very different, not just reporting system, but also governments and government structures.
No, thank you. And, that's always one of the big challenges sort of with capacity strengthening. You've heard me reference, and I'll speak to the global health security side because that's what I'm most familiar with. But, we have the elements, whether it be under AMR, like the TRACS reporting or the SPAR reporting on, the joint external evaluation reporting on AMR. And these are sort of, some of the core kind of capacity areas. And a lot of project reporting has been the aspects of, how many labs have you, done and that sort of thing. And so we're really, I'll say we're also really tackling that issue. I mean, that's something that we're considering. We also have the aspects of, okay, if you say you've supported 15 labs, does that cover 90% of the samples, or does that cover 1%? So I do think these issues, both of sort of, again, what does the data mean? Like understanding the denominators as we're talking about this, what is the actual coverage? It is one whole sphere, and then there's the next sphere, and then what are the impacts of that? Are we really seeing the reduction, as you said, in if it's like healthcare acquired infections or any of those elements. So I think that that's something that the global community continues to try to get at the best way. I mean, we have that also pandemic preparedness. It's like, okay, we have all these, but how do you actually test if we have got the capacity? So that was a very long answer to say we're working on it. We know that that's areas, and I think that that's something that also could be valuable in terms of for an element of what the global community takes on, especially as we're looking at UNGA 2024, where we've made a number of commitments since the Global Action Plan on AMR in a lot of venues, and I think we've got a great opportunity now to look at these sorts of things. Okay, now how do we tackle these sorts of really challenging questions? So thank you.
Thank you.
Dr. Petrillo, thank you so much. And a special thank you to everyone that's presented this morning. We've got great conversation going about this topic. More to come after we break for lunch. We'll be hearing from USDA and CDC. Please be sure to return by 12:20. We'll be promptly starting at 12:30. So get yourself situated in the meantime. Thank you all, and we will see you again in just 40 minutes. Take care.
Produced by the U.S. Department of Health and Human Services.